T score. Why you will not see improvement in the GT score? There is a question, there are 4 choices. The beauty of an MCQ is answer is written in front of you. You need that vision, that why and how this question has been structured. Okay, chalo. So that is how. So now for the days, we will try to have this, that get it into the thought process. But I think we have crossed the time limit for the day. Let us get back to our time. Let us get back to our one-shot program of the anatomy. But please do not forget to write the test after the session. All right. Chalo, take care and we will meet tomorrow.
Let's start. I know we are little. This is a time when everyone's a little tensed. Most of us most of the time we have a fake smile on our faces. We are thinking of something else. There's so much going through your mind. What if kind of questions are hovering your head? But guys, take a chill pill. I mean, just relax for now. Let's kind of just enjoy this process. Try to enjoy this process here, because what you can do is something which is possible in the present only. The future all depends on that how our process is. So how about we make our process wonderful, and I hopefully that the result also will be in our favor only. So in that, let us start our session. There are few, I would say, the instruction. Well, instruction, I'm sorry, it is a little harsh term, not an instruction. Let me rephrase. Some suggestions, humble suggestions from my side that I would say that you need to follow, if you could follow during this program. Guys, number one, I want all of you to please keep all your notes, your PDFs and all those annotated part and everything, books and everything aside here. I'll tell you the reason, because I'm not asking you to write down anything. Everything will be annotated here already. It's an animated PowerPoint here. I've really worked hard on this presentation. I hope you like it. And because we had this one shot session last year also, so like obviously there are like most of the things are the same only, but it's the way how it comes in. It's the thing which I want to anticipate, that before it comes onto the screen, I want you to think about it. If you have that annotated PDF or the last year one shot PDF or something like that, or even if your class notes with you, then anticipation will go a little less. So for your own good only, it will be really, really beneficial and you'll really enjoy it if you just keep everything aside and just listen to me for the next how many hours. Okay, it's more about visualization. I tried to put the presentation in such a way that you can visualize, understand, and learning. I kept it for the last, guys, because you can learn later on also. If there are 5 branches of a certain artery, you have to learn it also. You can do it a little later also. But the point is that you need to visualize it right now so that this picture stays in your head. So we need to develop the visual memory, and that is what I'm requesting you to be able to do. Don't worry, I'll give you a break also in between, like everyone is doing that. It's not that we'll be going for like good 4-5 hours continuously. So it may go for 4.5 or 5 hours, I believe. No, although I cannot make a pinpoint that exactly when it finishes here, but obviously it will go to the same amount of time only. But we'll do it in 2 sessions, guys. The first session we will be doing here, I'll be starting with the embryology. We'll be doing the limb, upper limb, lower limb. And histology is something that I'll be injecting in between only. Histology, guys, I know that we don't want to do the histology like at once. We don't want to discuss 20 slides of histology. So I've like chosen some 10-12 slides, important slides of histology. I'll just inject them in between. 2 slides here and there, 2 slides here and there. So throughout this one-shot program, we'll be discussing the histo part there. Okay. And the second session, which I'll give you a break of 15-20 minutes in between, and then we'll have a head, neck, face, the neuroanatomy, and the visceral discussion. Whatever I feel important about the viscera will be covered in that part. So first we're starting with the embryology, and we're going to start with the general embryology first here. Let's keep the session light, guys. Just don't be stressed about it. I know that the people who are attending this one-shot program, there are 2 types of crowd I'm catering right now. Some of you are my students who attended my class face-to-face, or maybe online, or maybe on some app, or maybe earlier, or maybe you read my notes. And some of the people who never studied with me. So it doesn't matter. It doesn't matter absolutely. I've tried to create this presentation in a way that everyone is benefited. Okay, so look at this picture, guys. This image here, this is an image which is being asked over and over again. I mean, from the last 2 years, they were asking this electron microscopic image in which they've given this picture where the ectoderm, endoderm, the 3 germ layers are visible, different part of mesoderm is visible, and they're asking the derivatives. And this is a kind of question which is not an end question. I mean, they have already asked about neural crest cells in this. They have asked about the paraxial mesoderm. They have a lot to ask. There are many other things which are also available in this to ask. Okay, so let's start first. What you're looking at, guys, you're looking at the three germ layers there, the ectoderm, the endoderm, and the mesoderm. Obviously, ectoderm above, the endoderm below, and the mesoderm in between. And all the three germ layers are derived from the primitive streak. There's a notochord also which is marked with that green color over there. And it's the notochord which is responsible for the development of the neural tube. You can see the neural tube just above that here. And that neural tube, which is actually derived from the ectoderm only, but that is derived from by the stimulation which came from the notochord. So it's the notochord which stimulated the ectoderm, converted the ectoderm into neuroectoderm, and that's where the neural tube came from. And then at the junction of the neural tube and the ectoderm, we have the cells which are called as a neural crest cells here. I may not be able to reach to that point here, although I'll keep trying that. So look at that point here. This is the point where you'll see the junction of the ectoderm and the neural tube, where the neural crest cells are present. Okay. We'll discuss more about this neural crest cells and the neural tube in a while. Let me just first go through this entire thing. And then look at this, all this colored for area they have shown here. Just next to the neural tube is a mesoderm, which is called as a paraaxial mesoderm. Neural tube is like an axis. So just next to the axis is a paraaxial mesoderm. Just next to the paraaxial mesoderm, we have intermediate mesoderm. The red one which is shown over there is an intermediate mesoderm. And then we have the lateral plate mesoderm, which is the laterally present here. We'll discuss more about lateral plate mesoderm, how it is dividing, but that's the lateral plate mesoderm. Okay. Out of all this, now let me just look at the intermediate mesoderm first. Let's eradicate the one which we don't require for now. Intermediate mesoderm, we will be discussing more about this in the later part, because intermediate mesoderm contributes to the formation of urogenital system. It will give rise to the genital ducts, mesonephric duct, paramesonephric duct, even genital ridge, which will give rise to gonads. They will be derived from the intermediate mesoderm. Now, what are those parts of intermediate mesoderm? What are those genital ducts, their derivatives and remnants? We will discuss them at the end. So just keep it on hold for now. So all I'm trying to do here is, let's just this intermediate mesoderm, I said, it will give rise to all the genital ducts. So let's forget about this intermediate mesoderm for a second. Let's get rid of this. And let's compare the two mesoderm here, that is a paraaxial mesoderm and the lateral plate mesoderm. And they are very much comparable to each other. If you know about one, you automatically know about another one. If I know the paraaxial mesoderm, I also know about the lateral plate mesoderm. So it's very, very simple to compare the two. Look, when you look at the paraaxial mesoderm, guys, paraaxial mesoderm, like if there's a neural tube here, the paraaxial mesoderm is present on both the sides. So along the entire length of paraaxial mesoderm, there is a ball-like condensation which will take place, and those are called as somites. So somites are the ball-like condensation which are formed from the paraaxial mesoderm, which are along the present on the side of the neural tube only. Now, people do ask me this, that, okay, what is the number of somite? I mean, initially the number of somite is more, guys. Now, somites are like 42 to 44 pairs of somite initially. And then the somites will keep on reducing. Some somite from the occipital regions are gone. Some somite from coccygeal regions are gone. And the somite number will come down to 36 to 38. But you know, sometimes the examiner get a little cranky and they ask you questions like, okay, tell what is the exact number of somite. Though I honestly, I don't believe that in the embryology, they should not be asking questions like this. But in past, not in the recent time, because recent time the NEET and INICET, they are at least they're sensible to ask the logical questions. They used to ask the question in which they ask like a particular number. That just tell what is the number. So if the examiner being the Sardar and the Sardar asks you that, okay, kitne somites hai, how many somites were there? Your best answer there will be 37. It's 36 to 38 pairs of somites which are there, but 37 pair is the best answer. It is according to the Langman, I'm telling you. The Langman has quoted 37 in that here. But again, the number of somite should be between 36 to 38 pairs. So somites, guys, these are ball-like condensation. As I said, if you look at the picture of the somite, this is how the somite will look like. So if this is a neural tube here, you can see that's a neural tube in the center. And look at this paraaxial mesoderm. And then on the paraaxial mesoderm, you can see this ball-like condensation present here. These are called as somites here. So this view is actually from the top. When you remove the ectoderm and then you're looking at, then I can see, okay, somites are visible only after removal of the ectoderm only. Somites, what they give rise to? Somites divides into different parts called as a dermatome, sclerotome, myotome. If you don't remember that, doesn't matter. Just remember, guys, somites will give rise to the dermis of the back, axial skeleton, and they will also give rise to the skeletal muscle. The skeletal muscle, except those skeletal muscle which are derived from pharyngeal arches, because that's a different story altogether. So somites will give rise to what? Dermis of the back, the axial skeleton, that is ribs and vertebrae. Very, very recent question, guys. Last year they asked this question only, that ribs are derived from where? And the picture was something like that, where you have to point out the paraaxial mesoderm. Somites will give rise to the axial skeleton, and somites are coming from paraaxial mesoderm. Okay. And we have skeletal muscle, like all skeletal muscle you can think of, upper limb, lower limb, and any kind of skeletal muscle, even axial skeletal muscle, they're all coming from somites only, except those which are like pharyngeal arch skeletal muscle. That is a different story, I already told you. Okay. What about lateral plate mesoderm? As you can see, lateral plate mesoderm is divided in two parts. If you look carefully, the lateral side of that embryonic plate, you can see that there is a coelom over there. And because of the coelom, the lateral plate mesoderm is divided in two parts. We have this, the somatopleuric and splanchnopluric lateral plate mesoderm. One which is present above, close to the ectoderm, that is somatopleuric. And the one which is below, toward the endoderm, that is a splanchnopluric lateral plate mesoderm. Somatopleuric and splanchnopluric lateral plate mesoderm. We already know what should be derived from the lateral plate mesoderm. I told you whatever is not derived from the paraxial mesoderm is derived from the lateral plate mesoderm. So I already have a list in my head. I know, okay, dermis ho gaya, dermis of the back is done, axial skeleton is done, and skeletal muscles are done. So what is left, guys? Dermis of the frontal limbs are remaining, appendicular skeleton is remaining, and smooth and cardiac muscles are remaining. But we need to decide that out of all these, which I just said, which one of them are derived from the somatopleuric and which one are from the splanchnopluric lateral plate mesoderm. So somatopleuric lateral plate mesoderm is the one which will give rise to what? It will give rise to the dermis of the front and limbs. Obviously, dermis makes sense. It should be from the body wall only, dermis of the front and limbs. It also gives rise to the to the appendicular skeleton here. Upper limb and lower limb bones are also derived from this somatopleuric lateral plate mesoderm. What is left? Skeletal muscles are from here. So what about the splanchnopluric? This will give rise to what muscle? It will give rise to the smooth muscles and cardiac muscles. Obviously, there are some exceptions in smooth muscle, and cardiac muscles are only at the cranial end. But at least I know that broadly the smooth muscle and cardiac muscles are derived from splanchnopluric lateral plate mesoderm. So guys, if they give you this picture, here, then you should be able to identify that, okay, where and what it is derived from. Chali. Moving on. Now, let's talk more about this neural tube and the ectoderm, guys. Neural tube and the ectoderm. Now, when you look at the neural tube, guys, how exactly the neural tube is formed and what neural crest cells, where they're coming from here. Just look at this small, the animation that on the screen here. Now, what you see, guys, this ectoderm, it starts to fold on. I told you that notochord will stimulate this. Now, this ectoderm starts to fold and that forms a neural groove. And once this neural groove keeps on folding, the folds will come close to each other, and the cells which are present at the margin of the folds, these cells, these are the ones which are the neural crest cells actually. And eventually what will happen, the neural tube will separate, the neural crest cells will proliferate and they will leave that area, and ectoderm will also separate. So all the three will become a separate entity here. Look at that. Now ectoderm is separated, neural tube is separated, and we have a junction of the ectoderm and the neural tube where we have the neural crest cells, that is the neural crest cells. So this is just to tell you that how exactly it is done. So the ectoderm only it folded with the stimulation came from where? From the notochord, and that's how the neural tube, notochord is this neural tube is formed, and the neural crest cells are separating themselves from the ectoderm as well as from the neural tube. And I hope you all know that neural crest cells are also called as a fourth germ layer. They're giving rise to so many structures that they also called as a fourth germ layer. What about the notochord, guys? Notochord, after it stimulates the nervous system formation, notochord will just have some remnants only. And the remnants of notochord is what? That is apical ligament of Dens, that is one. Membrana tectoria and nucleus pulposus. If you don't remember all three of them, doesn't matter. At least nucleus pulposus you should remember that here. So guys, notochord is the one which will, that's the notochord here. These are remnants of notochord that you're looking at here. That is a nucleus pulposus, apical ligament of Dens, odontoid process, guys. There is a ligament present on the odontoid process. That is apical ligament of Dens, and tectorial membrane or membrana tectoria. It is just the continuation of posterior longitudinal ligament. Membrana tectoria is just a continuation of posterior longitudinal ligament. Honestly, not very, very important. Nucleus pulposus is something which is likely to be asked if this question is ever asked in the exam. Okay, now what about the neural tube and the neural crest cells? The origin is same only. They both are formed from the ectoderm only. One becomes neural tube, one becomes neural crest cell. So there has to be some similarity between them. And the similarity lies in, guys, that neural tube will give rise to the structure which corresponds to the central nervous system. So it's more like central nervous system and the, you can say the supporting cells of central nervous system. Brain and spinal cord, it's central nervous system. Oligodendrocytes will do myelination for central nervous system. Astrocytes will form blood-brain barrier. Ependymal cells, it forms the ventricles lining, also part of central nervous system. And retina and retinal pigment, guys, optic nerve, retina, they are all extensions of brain only. So if you look at that list over there, all you have to think about ki yaar, ye to this central nervous system. Anything which is, if you can correlate something with the central nervous system, it is directly or indirectly derived from the neural tube only. So the point is central nervous system is the keyword there. When it comes to the neural crest cells, now we have two types of derivative there. We have some derivatives which are corresponding to peripheral nervous system, and some of the derivatives which are mesenchymal derivative, which looks like mesodermal in origin. So if you look at this, like there's a long list for the neural crest cells, guys, but my recommended list is this one. So if you look at this list of the neural crest cell derivative, now first look at these three here, all ganglion cells. Now, it doesn't matter which ganglion are we talking about. Is it a parasympathetic ganglion? Is it a sensory ganglion? Is it a inferior mesenteric ganglion? Or is it a sympathetic chain? Or is it a dorsal root ganglia? Ganglia word aate hi samajh jao. The moment you say the word ganglia, obviously it is a part of peripheral nervous system. Central nervous system mein to we have nuclei. In peripheral nervous system we have ganglion. So any ganglion anywhere in the body, they are all derived from neural crest cells. Enteric plexus, myenteric plexus, Meissner's plexus, Orbeck's plexus. You read about all these plexes, right? And these plexes are present in the wall of GIT, part of peripheral nervous system. That's away from the brain and spinal cord. Schwann cells, guys. Schwann cells will do the myelination for what? Peripheral nerves. Like oligodendrocytes were doing the myelination for central nervous system, the Schwann cells will do the myelination for peripheral nerves here. Adrenal medulla, parafollicular C cells, melanoblast, like adrenal medulla, guys. Adrenal cortex, the outer part of adrenal gland. Adrenal cortex is derived from the intermediate mesoderm, and adrenal medulla, which is having a sympathetic ganglion also inside, that is derived from the neural crest cells here. So adrenal gland you can divide in two parts. The outer part, the cortex part of the adrenal gland is from intermediate mesoderm, and the core part, the medullary part here, it is from the neural crest cells. Parafollicular C cells here. Parafollicular cells or C cells, these calcitonin producing cells, they are not derived from the pharyngeal arches. It's the neural crest cells which will migrate into pharyngeal arches, and then they will give rise to the parafollicular C cells. So if you have option to choose between the neural crest cells or ultimobranchial body or pharyngeal arches, whatever is given, your definitely best answer for the parafollicular C cells is the neural crest cells. Okay, melanoblast, guys, except for retinal pigment, leave the retinal pigment there, and except for retinal pigment, any other pigment epithelium you can think of, all melanoblasts, melanocytes here, that is all derived from the, from the neural crest cells. And then we said some mesenchymal derivative. Especially when you look at the head and neck structures, बहुत सारे structures को देख के ना आपको ऐसा लगेगा कि यार this should be derived from the mesoderm. Like there are many structures you will see and it will look like okay, this should be derived from mesoderm, like skull bones, dermis of the head and neck, like cartilages, so dentine. But in head and neck region, that mesenchyme is actually coming from neural crest cells only. So the skull bones, most of them, the dentine here, the pharyngeal arch cartilages, head neck, the dermis of the head and neck region, that is all coming from the neural crest cells. Okay. And then we have a conotruncal septum, guys. Conotruncal septum, I'll discuss more about this. Conotruncal septum, it's a septum which is dividing, partly it is dividing the ventricle and partly it is dividing the truncus arterius. It's a conotruncal septum. It's between the conus and the truncus. Conotruncal septum. It's a septum which is dividing the heart, ventricle, interventricular, forming a part of interventricular septum, and it is also dividing the truncus arterius. So collectively we call it a conotruncal septum. Dr. Doolittle, yes, beta, this is, yeah, if you talk about the cell body, so obviously it is inside the central nervous system. So that cell body is derived from the CNS part, but the axon which is going out, that is the peripheral nervous system. That is coming from the neural crest cells. Okay, chalo. So as I said, when you think of the neural tube, it's about the central nervous system mainly. And when you think of the neural crest cells, it's mainly about the peripheral nervous system. Like mainly, I'm not saying everything here, that their peripheral nervous system derivatives are there. And you also see then some of the derivatives over there are the mesenchymal derivative. So this is a little about the general part here. I mean, I hope you understood a little about that, what is paraxial mesoderm, the intermediate mesoderm and lateral plate mesoderm is doing. Neural tube, how it is formed, notochord, what are the remnants here, and ultimately the neural crest cells and the neural tube derivatives. Okay, guys, I may not be able to like look into the group right now because I can see they are posting some questions in there, but you know that will kind of break our rhythm here. So I'll definitely answer your questions, but I hope that you don't mind if I do it like after the session. Okay, chalo. Now guys, from this portion, let's move on to some development of some of the important structures. Like one is diaphragm, guys. Without a doubt, diaphragm development is extremely important. Diaphragm, development of the diaphragm, this question has been asked like since ages, guys. I can follow this question all the way back to 2005 and all that. Like even those examination, I remember the development diaphragm, or aaj bhi पूछते हैं development diaphragm. So diaphragm is derived from 4 structures, as you can see A, B, C, D marked over there, because they're now asking image-based question also. You should be able to identify them. A is the body wall mesoderm. You can also call it the cervical myotome. Now, what is a body wall mesoderm? Body wall mesoderm is a somite only. Paraxial mesoderm. Body wall mesoderm is a paraxial mesoderm I'm talking about here. And why I'm saying cervical somites or cervical myotome? Because diaphragm ka nerve supply comes from phrenic nerve, and phrenic nerve root value is C3, C4, C5. So it tells me that diaphragm is the muscular part of the diaphragm is derived from the cervical myotome only, the cervical somites only here. So that is the one which will give rise to the muscular part. The major muscular part of diaphragm will come from there. The point A, more toward the posterior lateral side. Then B is the dorsal mesentery of esophagus. Now, when you talk about the mesentery, we talk about the mesentery of the stomach, we talk about mesentery of the intestine, we talk about mesentery of colon, but we never talk about mesentery of esophagus. Well, guys, developmentally there was mesentery of esophagus also, but that mesentery of esophagus is utilized to form the crura of the diaphragm or crus of the diaphragm here. That is coming from the dorsal mesentery of esophagus. Then look at most anteriorly, that's C. That is a septum transversum. What is septum transversum? It is undivided lateral plate mesoderm. Septum transversum is an undivided lateral plate mesoderm. Septum transversum, before the folding of the embryo, it is present at the cranial end, and with the folding of the embryo, the septum transversum actually came in this area. And then it gives rise to multiple structures, to the fibrous pericardium, central tendon of diaphragm. It contributes to the liver also, liver stroma. So in the septum transversum, in the developing liver, it contributes to the central tendon, the central tendon. So just don't be confused, guys. This is a picture of a developing diaphragm. Don't expect to see the central tendon in the center right now. Septum transversum came in here, and then eventually it will go inside and become a central tendon here. So when you look at a developing picture here, you may confuse the option B with septum transversum. Don't do that here. Septum transversum is most anteriorly placed, and eventually it will form the central tendon. And then look at the D, that is the dark pink over there, guys. This is the pleuroperitoneal membrane. Now it's the membrane, guys, which is basically separating the pleural cavity and the peritoneal cavity. That is called as a pleuroperitoneal membrane. And that muscles which are coming from the above, from the body wall mesoderm, these muscles will only invade it. So there's a very thin membrane formed there, and that pleuroperitoneal membrane is invaded or incorporated by the muscles only. But now there are two conditions. Let's say if this pleuroperitoneal membrane is absent, bana hi nahi. If there is no pleuroperitoneal membrane, there is a persistence of pleuroperitoneal canal. There is no membrane over there, so there is a persistence of the pleuroperitoneal canal. And if that is the case, obviously that leaves an opening toward the posterior lateral side, and that is called as a Bogdalek foramen, and that leads to the congenital diaphragmatic hernia. That leads to the congenital diaphragmatic hernia. As you can see that picture over there, that video over there, you can see toward the posterior lateral side, that's the Bogdalek foramen, and you can see the intestine herniating through it here. More common toward the left side, so obviously it will go above here, and these intestines will obviously push the lung, and they will not allow the lung to develop, cause the lung hypoplasia. Look at these intestines here, and they're pushing the lung, causing lung hypoplasia, the left lung hypoplasia. The congenital diaphragmatic hernia, correct. Then we have a pleuroperitoneal membrane incorporated by the muscle. Now guys, let's say the pleuroperitoneal membrane is formed. In this case, there was no pleuroperitoneal membrane. No membrane. It was a canal. But let's say the pleuroperitoneal membrane is formed, but there is a failure of muscle to incorporate that. If muscles will not incorporate that, what will happen? In that case, there will be a thin membrane which will be separating the pleural and the peritoneum, and that membrane will not be able to stop the intestine to come above. So that is also leading to a kind of, although it's not a true hernia, it is called as an eventration of the diaphragm, guys. That is called as an eventration of diaphragm. Look at this very thin membrane over there. On the scissor you can see that's a very, very thin membrane over there, and that is a membrane which is separating the pleural cavity and the peritoneal cavity. So it's not a complete foramen, it's not a complete opening over there, but still it is like causing the kind of hernia only. It's similar to congenital diaphragmatic hernia, but the difference between the two cases, in the first case, when the absence is there of the pleuroperitoneal canal, it is leading to the CDH, and in this case, the pleuroperitoneal membrane is formed, but there is no muscle which is forming in it here, so membrane is very, very thin, and it is not able to stop the intestine from herniating above. Right, so that is about the about the diaphragm development and the conditions. Chali sir, let's move on. Now moving on to the pharyngeal arches. Now when I talk about pharyngeal arches, guys, I'll tell you something. Everything about pharyngeal arch is important. Pharyngeal arch, ectoderm, endoderm, pharyngeal arch arteries, pharyngeal arch skeletal cartilages, everything about pharyngeal arch. In your embryology preparation, please do keep pharyngeal arches as your priority. 100%. Okay, just to give you a better idea of the pharyngeal arch, guys, look at that picture over there. And that line is telling you that if you take a section through the pharyngeal arches, through a coronal section, now that's how this coronal section is going to look like. So you're looking at the pharyngeal arches over there, that's one arch over there, this one arch in here. And in the core of the pharyngeal arch, we have mesoderm, that's a mesoderm inside. On the inside, that is an endoderm, and outside, that is ectoderm. You have an endoderm and ectoderm here. What you'll also see that spaces on the outer side. On the outer side, all those spaces are called as the clefts. Between the pharyngeal arches, all those are clefts here, and the spaces in the inner aspect of the pharyngeal arches are called as pouches. So clefts and pouches. So our discussion here is about the clefts and pouches only. Okay. So now we got a rough idea about how pharyngeal arches are present. We have a core of mesoderm, endoderm on one side, ectoderm on one side, and then we have like clefts and pouches. Clefts are on outside and pouches are on the inside. Now the mesoderm of the second pharyngeal arch, look at this image, guys. The mesoderm of the second pharyngeal arch, that's the second pharyngeal arch. Look at the green color here is corresponding to the ectoderm, and the red color here is corresponding to the endoderm. So obviously all these are what? Pouches. Where I'm pointing it right now, all these are pouches, and all these are clefts. Look at my thumb here right now, it is pointing toward the clefts. All these are clefts. Ectoderm of the second pharyngeal arch will overgrow and joins below, and that's why what happens, all these clefts are obliterated. All the clefts are obliterated here. The second cleft, the third cleft, and fourth cleft are obliterated. And this space over there, this embryological space present over there is called as the cervical sinus. This cervical sinus, usually it is obliterated, but let's say if the cervical sinus, it fails to obliterate, if it persists even after birth, that will give rise to the cyst. I'm sure everyone knows that. That is a branchial cyst. The painless, harmless swelling that you see along the sternocleidomastoid, guys, that is a branchial cyst. It is nothing but the persistence of the cervical sinus. There is a persistence of cervical sinus. Okay. Then we have the ectoderm of the first arch. Look at it. If you look at the out of all the clefts, only first cleft is the one which persists. All other clefts are gone. Only first cleft persists here. And if you look at the side of the head and neck, there is only one opening present on the side, and that is external auditory canal. So guys, the first cleft will give rise to the external auditory canal, and it will also give rise to the outer layer of tympanic membrane. Which makes sense, guys. Outer layer of tympanic membrane and the external auditory canal lining, it is ectodermal. It is made up of skin only. So first cleft will give rise to the external auditory canal and the outer layer of tympanic membrane. That's about the cleft. So nothing much in the cleft here. The cervical sinus, it usually obliterates all the cleft here. If it persists, then the branchial cyst, and only derivative we have for the first cleft only. But when it comes to pouches, now look at pouches, all of them are there. So now we have the pouch number 1, 2, 3, 4, which I marked over there, right? That those are all pouches. First pouch, and you can get the idea of the first pouch from the first cleft only. If the first cleft is giving rise to the outer layer of tympanic membrane and external auditory canal, then the first pouch will give pouch cleft will give rise to the external auditory canal. So first pouch will give rise to the inner layer of tympanic membrane, middle ear cavity, and the two extensions, that is eustachian tube anteriorly and mastoid antrum posteriorly. So first pouch derivative, pouch means endoderm only. First pouch will give rise to the inner layer of tympanic membrane, which is facing toward the middle ear. So lining of the middle ear cavity also. And just think about the two extensions of the middle ear, that is the eustachian tube anteriorly and mastoid antrum posteriorly. Second pouch will give rise to the palatine tonsil, to be strictly speaking only the lining epithelium of the palatine tonsil. Third pouch will give rise to the thymus and inferior parathyroid gland. Now don't forget that it's thymus and inferior parathyroid gland, whereas superior parathyroid gland will come from the fourth pouch here. So superior is below and inferior is above. And this is because of thymus only. You know, thymus ultimately will migrate into the mediastinum. So when thymus migrates downward, it also brings the inferior parathyroid along with it here. So thymus and inferior parathyroid together, and that is it. Now, we don't have fifth pouch, because we don't have fifth arch. So we don't have fifth pouch, but we have a remnant of the fifth pouch, and that remnant of fifth pouch, it gives rise to something called as the ultimobranchial body. A remnant of fifth pouch will give rise to ultimobranchial body. If there is an anomaly in the development of the third pouch or fourth pouch, I'm sure you read about that, guys. That is one of the most common microdeletion syndrome you must have read about. That is a DiGeorge syndrome, when there is an absent thymus and hypoparathyroidism here. So if there is an anomaly of the third pouch and fourth pouch, sometimes only third pouch or sometimes third and fourth pouch both, that is the most common microdeletion syndrome, the DiGeorge syndrome. And the digital syndrome, we say that there's absent thymus, there is hypoparathyroidism. That is the case of the digital syndrome. This question is asked as an image-based question in the exam twice, guys. Twice it was asked an image-based question. They just put an arrow on the different pouches in the cleft and they've asked you that anomaly of the which of the pouch or which of the cleft will give rise to the to this absent thymus and hypoparathyroidism. And about the ultimobranchial body, I already told you, don't bother about it. Ultimobranchial body actually is not giving rise to anything directly. It's the neural crest cells which migrate into ultimobranchial body and they will give rise to the parafollicular C cells. So if the question is asked, C cells are derived from where? Still, your best answer is neural crest cells. Ultimobranchial body is the second best answer. It's just the site where the neural crest cells will migrate. That's about the pouches, about the cleft, guys. One cleft and then all about the clefts here, right? Okay. Then, guys, we have the pharyngeal arch cartilages. Now, somebody is asking about the cartilages only. The pharyngeal arch cartilages. When you look at the cartilages inside the pharyngeal arches, they are derived from the neural crest cells only. They're coming from neural crest cells, the mesenchyme of neural crest cells. If you look at these different colors here, it tells you about which cartilage is coming from where. Like first arch cartilage will give rise to the malleus, it gives rise to incus, and it also gives rise to the Meckel's cartilage. Now, Meckel's cartilage is something which will give rise to Meckel's cartilage will give rise to some part of the malleus also. Meckel's cartilage directly will not give rise to the much part in the mandible. See, mandible is a flat bone. I mean, mandible is a part of a skull bone, and skull bones are membranous in ossification. And if a bone is coming from membranous ossification, then it doesn't need a hyaline cartilage. Meckel's cartilage is hyaline cartilage only. So Meckel's cartilage directly is not giving rise to too much in the mandible. He will just have a remnants only. But it is not wrong to say that first arch will give rise to the mandible and maxilla and the zygomatics and squamous temporal. They are all indirectly coming from first arch only. But directly, if I say that from the derivative from the first arch, direct derivative says the Meckel's cartilage, it is the malleus and the incus. Second pharyngeal arch will give rise to the stapes. Look at the blue color over there, the styloid process, the stylohyoid ligament, lesser cornua of the hyoid bone, and some part of the upper body also. If you say lesser cornua, that is still okay, but even upper body of the hyoid also. Stapes, guys, stapes except the footplate of the stapes. Stapes except the footplate of the stapes is derived from there. The styloid process, stylohyoid and stylohyoid ligament and lesser corn of the hyoid along with the upper part of body of hyoid also. Look at the yellow color over there. The greater cornua of the hyoid bone and the body of hyoid, mainly the lower part of body of hyoid, it is derived from the third pharyngeal arch. And then fourth and sixth arch, they collectively give rise to the laryngeal cartilage. I would recommend you not to read them separately here because the different authors have different opinion on that. And there's a lot of controversy behind that. So I would say that thyroid cartilage, cricoid cartilage, in fact, all laryngeal cartilages are collectively derived from fourth and sixth arch. So first arch shown in the orange there, the second arch in the blue, the yellow is showing the third arch, and the red and the green collectively showing you the derivative of fourth and sixth arch. Exactly. Otic capsule is coming from the foot plate, giving us the foot plate of the stapes and the ligament. Right? Okay. Now moving to the pharyngeal arch arteries. But before moving to the pharyngeal arch arteries, because the next topic is quite animated here, you will see all different arteries coming in here. Let me just take a very quick feedback in the group here because I'm not talking too much in the group in between. So guys, is it going fine? Am I going with a fine speed? I mean, because we have to cover a lot. So if you find it a little fast, so do let me know. If the speed is okay, please do let me know that also so I can modify it right away only. I'll just wait for your response and then immediately I'll start with the pharyngeal arch arteries after that. Okay, that's perfect. Thank you. Chalo guys, perfect. Then you just kind of elevated my mood immediately. So the pharyngeal arch arteries. Now again guys, please look at the screen here because this you will not find this in the last year, the one shot, the way I've prepared these slides very recently only for you guys. Now pharyngeal arch arteries, we have two dorsal aorta guys. We have right and the left dorsal aorta. The name says dorsal aorta, so they're at the back. Look at that. Let's say this is a right dorsal aorta and this is a left dorsal aorta. The right dorsal and the left dorsal aorta. So dorsal aorta, Nami dorsal aorta, they are at the back here. And then we have the more in front, the developing heart is there, and the cranial end of the developing heart, that is called as the aortic sac, which divides into the right horn and the left horn. Look at that's aortic sac here. It is dividing into the right horn and the left horn. And this aortic sac, which is dividing into right and left horn, it is connected with the dorsal aorta, the right and left dorsal aorta, by 6 pharyngeal arch arteries, like 1, 2, 3, 4, 5, 6, like the 6 arch arteries there, and that's how they are connected to each other. Okay, if it's a bit fast, I can kind of try to reduce the speed a little, but I have to cover a lot, and I don't want to like make you sit the whole night. So the arch arteries, we have a first arch artery. You can see that's the second arch artery, the third arch artery, the fourth arch artery, fifth and the sixth arch artery. So they are connecting this aortic sac, the right and left horn of aortic sac, and they're all going backward and under connecting to the dorsal aorta. So I hope you got this picture in here, that these are pharyngeal arch arteries, 1, 2, 3, 4, 5 and the 6th arch. Initially 6 arches are there, 5th arch disappears later, but these are the 6 arches that we got initially. Okay. Also, I want to mention one more artery here, because next slide will use this picture, but in a more like light format. There is an artery which is coming from the dorsal aorta, and that is called as the 7th cervical intersegmental artery, guys. 7th cervical intersegmental artery. What is the 7th cervical intersegmental artery? Initially dorsal aorta is having multiple branches. We have 7th cervical intersegmental, thoracic segmental, lumbar segmental. Just segmental arteries are there. But I just need this 7th cervical intersegmental artery. That is right side, and this is left side here, and this will be playing some role in the formation of subclavian artery. We will see that here. So I hope you got this basic picture first, that we have a aortic sac, we got the right and the left horn, we got 6 pharyngeal arch arteries going backward and connecting to the dorsal aorta, right and left dorsal aorta, and that is the 7th cervical intersegmental artery. Out of other arteries are also there, but I've just chosen the 7th cervical intersegmental artery there. Okay. Now let me take this picture once again, but I'm just making it very faded here so that we can only look at the arteries which are going to persist here. There we go. So the same image, guys, the same picture again here, but it's very, very faded image here. Let's now start with the main artery first, guys. Now you know this is the aortic sac, and you're looking at the right and the left horn of aortic sac. Now guys, I'll keep showing you one artery here, and there will be text which will come onto the side here. I wanted to keep on comparing it so that you can kind of correct, you can check your slides also simultaneously, because the same slides are going to reach you as well. Now aorta is derived obviously on the left side. So the development of aorta will take place by what? It is by the aortic sac, number 1, left horn of aortic sac. Then it's a left fourth arch artery. Look at that fourth arch artery, left fourth arch artery, and the left dorsal aorta. But I'll tell you, in the examination, you don't have to remember that much. If you just remember the left fourth arch artery, that I can promise you that is more than enough. Left fourth arch artery is more than enough. But to discuss the entire development, I need to tell you that there are 4 components there. Just check out those components, guys. Aortic sac, just check out on the side. Then we have a left horn of aortic sac, the left fourth arch artery, and that's left dorsal aorta. Left dorsal aorta. Thank you. I'm really looking forward to all your messages. I cannot curtail myself, but from looking away from the phone. But I need to focus right now. So this is the arch of aorta. Now, what about brachiocephalic artery, guys? Brachiocephalic artery has to go toward the right side, and obviously brachiocephalic artery will divide into the again common carotid and subclavian. Bas right mein to jana hai. So brachiocephalic artery is by this only. The right horn of the aortic sac will give rise to the brachiocephalic artery. Is it correct over there? Right horn of aortic sac. AS is aortic sac there. Okay. Now let's talk about the artery which is on both the side. That is common carotid and subclavian. Look at the guys. Look at the third arch artery. I want you to focus on third arch artery. Third arch artery on both right and left side will give rise to common carotid and internal carotid, whereas external carotid artery will come out as a bud only. Third arch artery will give rise to common carotid as well as internal carotid, which will continue above also. No need to discuss that. And external carotid artery will come out as a bud, as in vasculogenesis from that artery here. So it is not wrong to say that common carotid artery is derived from the proximal part of third arch artery, and internal carotid artery is by the distal part of the third arch artery. External carotid is just like a bud only. So common carotid is by the proximal part of third arch artery, and internal carotid is from the distal part of third arch artery. CCA is by proximal part, guys, and look at that. ICA is from the distal part of the third arch artery. Let me bring those arteries back to you. 7th cervical intersegmental artery. There we go. That's a 7th cervical intersegmental artery. The left side and the right side. Abhi left side, no problem, guys. Left side 7th cervical intersegmental artery is now looking at directly coming from aorta only. So left 7th cervical intersegmental artery will give rise to left subclavian. Finished. Left subclavian artery, look at that, left subclavian artery. It is by the left 7th cervical intersegmental artery. Only this artery is enough to form the subclavian artery. No problem. But when you look at the right side, now this is a puzzle to be solved. On the right side, only 7th cervical intersegmental artery is not enough. I need something more there. I need this 4th arch artery also to contribute to that. So what will happen? The 4th arch artery will also contribute here, like it will join with that. Some part of dorsal aorta also, like I'm ignoring that, that's not very important. So 4th arch artery of the right side and then 7th cervical intersegmental artery of that side collectively will give rise to the subclavian artery of the right side. Right subclavian artery, very important, guys. Subclavian artery development, anomalies of subclavian artery, and I say this in my regular class also, that then one artery that you should not leave ever is subclavian artery. Everything about subclavian artery is important. So right 4th arch artery, this one, and then 7th cervical intersegmental artery. So quite a difference between the right and left subclavian artery. Then this LB here represents the lung buds, developing respiratory buds and lung buds. And obviously lung buds are invaded by the artery only, and that is a 6th arch artery. Look at that, guys. You can see 6th arch artery is invading the lung buds. So it tells me obviously what arteries are those? Pulmonary artery. That means this portion here is giving rise to pulmonary artery. So is it the entire 6th arch artery? No. Only the proximal part of the 6th arch artery forms the pulmonary artery. Proximal part, whether it's right side or left side, proximal part of 6th arch artery forms the pulmonary artery. Whereas the distal part of the left 6th arch artery, distal part of left 6th arch artery will give rise to what? What is that? That is ductus arteriosus. That is a ductus arteriosus. So ductus arteriosus, look at that. Just keep on comparing the text over there, guys. Distal part of the left 6th arch artery. If you keep on comparing the text right away, now you don't have to revise it later. I know we have to just finish off this with anatomy tonight, and maybe tomorrow you'll be reading through all these PDFs and everything, and you just need to get over with this here. Just tomorrow there's a new subject here. So obviously we have this only, this is this present is the time that we have to cover this subject here. So guys, just please focus. So that's a ductus arteriosus. And you know that after birth, the ductus arteriosus will close, will become ligamentum arteriosum. And this also was a question asked in the INICT, that patent ductus arteriosus. They gave the picture of the patent ductus arteriosus, and the question was, it is because of the anomaly of which arch artery? And imagine they don't even ask the distal and proximal part. They're just asking right, left, and which arch artery. So 6th arch artery of the left side, precisely distal part of the left 6th arch artery forms ductus arteriosus. And if it persists even after birth, that is patent ductus arteriosus. Let me also resolve one more question here, which is asked in the NEET and INICT both, about the recurrent laryngeal nerve, guys. Now look at the left recurrent laryngeal nerve. All of you please look at the screen. If this is the recurrent laryngeal nerve of the left side, look at this recurrent laryngeal nerve going below the distal part of 6th arch artery. And this distal part of the 6th arch artery will persist. Even after birth, it will persist in the form of the artery, or maybe a ligament, or maybe some fibrous structure. Something will be there. Some anatomical structure will be there. And that's why this recurrent laryngeal nerve never got a chance to go above this level. That's why your left recurrent laryngeal nerve is longer. But if you look at this side here, there is no distal part of the 6th arch artery. There is no 5th arch artery. So ultimately, recurrent laryngeal nerve of this side will hook below the 4th arch artery. And guys, 4th arch artery on the right side forms subclavian. That's why your right recurrent laryngeal nerve is below the subclavian artery, and your left recurrent laryngeal nerve is below the arch of aorta and ligamentum arteriosum. So it's a longer recurrent laryngeal nerve in that case. Okay. So left recurrent laryngeal nerve hooks under the left 6th arch artery, which persists in the extrauterine life. Look at the text here. I've just given the relevant text here, so that when you read that, if you get a question, you know, okay, what exactly we need to, what language we need to look at here. Let me read that for you guys. Left recurrent laryngeal nerve hooks under the left 6th arch artery, which persists in extrauterine life also. Obviously, it is persist in extrauterine life as ductus arteriosus, ligamentum arteriosum, fibrous eminent. Kuch to hoga na? And this nerve will never go above here. And on the right side, neither we have the distal part of 6th arch artery, nor we have 5th arch artery. So obviously, recurrent laryngeal nerve is present below the 5th arch here. Thank you, Neha. I hope I live up to this throughout this presentation. Okay, so that is about and let's do one thing, guys. Whatever the arteries are left over there, let me just shoo them away. Like let's give them off. Look, does it look like I've tried it? I hope it looks like that how the arteries are present in human being. Though I can try it a little better next time. I'll try to formulate a more curved lines or something. So, but yeah, that's the arch of aorta. You can see this, the brachiocephalic artery. You can see one common carotid, and you can see subclavian over there. You can see common carotid and subclavian over there. You can see the pulmonary arteries, which obviously is not coming from the aorta. That's from the pulmonary trunk. And then we have a ligamentum arteriosum. Okay. Thank you. I kind of like doing these little animations here, and if it comes good, then nothing like that. Chalo. Let's get back to the story again. Now, guys, let me just tell you a little about the abnormal subclavian artery. Now, that's a picture I took it from the IBSing only, so it's a picture which is like well known to everyone. In this, they have shown the aorta and the pulmonary trunk separated. Now, if you're looking at this is the aorta, that's a pulmonary trunk completely. Now, truncus arteriosus is separated here. Now, guys, the condition here is if the right side fourth arch artery is obliterated. If right side fourth arch artery is obliterated, then where the subclavian artery will come from? If the fourth arch artery of the right side is obliterated, then guys, this artery needs to persist. Generally, this artery is not there. If I go back and show you that that artery vanished. So generally, this artery will not. That means this is a caudal part of what? It's a caudal part or lower part of right dorsal aorta. This is the left dorsal aorta. This is the right dorsal aorta. Caudal part of the right dorsal aorta. This will persist now because there is an obliteration of the fourth arch artery, and that will give rise to the abnormal subclavian artery of the right side. Look at that, guys. Now this subclavian artery will be formed like this here. Instead of coming from fourth arch there, the subclavian artery will be coming directly from the aorta because there is a persistence of the caudal part of right dorsal aorta. That is only when the fourth arch artery is not persisting, and that is the abnormal right subclavian artery. The reason it is abnormal right subclavian artery, guys, because this artery is coming from the left side. Aorta is on the left side, and imagine the artery is coming from left side, so obviously it must be passing behind the esophagus, causing dysphagia lusoria. Look at that artery over there. This artery is look at this artery is going backward. It is passing behind the esophagus here, and then it is going toward that side here. That's the abnormal right subclavian artery causing dysphagia lusoria. Rightly said, that is causing the dysphagia lusoria. Rakesh dear, I'm really sorry. I will not be able to share this PowerPoint with you because they are being misused that way. But PDF will be there, and it's a very meticulous. Every step PDF is there for sure. So whatever, like right now, what you're looking at in the picture, that entire PDF will reach you. But I'm really sorry. I will not be able to give up the PowerPoint. It's a core hard work which I've put in. I think I deserve that to keep that PowerPoint with me. I hope you don't mind that. Okay, so guys. Overall, if you look at the pharyngeal arches, like if you look at the first arch, second arch, third arch, fourth and fifth and sixth arch. Abhi first and second arch, we did not discuss anything about first and second arch because first and second arch arteries they just have remnants only. First arch artery remnant is the maxillary artery, and second arch artery remnant is the stapedial and hyoid artery. Just remnants only, guys. First arch artery remnant is maxillary artery, and second arch artery remnant is hyoid and the stapedial artery. These are the arteries which are present in the embryonic life, right? That is artery present in embryonic life. Third arch, fourth arch, fifth arch, and sixth arch. Now, I want you to, because I hope that you've not opened any book or anything in front of your notes. Think about it, guys. Third arch artery was giving rise to the common carotid and then internal carotid, right? Common carotid and internal carotid. That's okay. Sorry, I was trying to hide it. Third arch artery is common carotid and internal carotid. Fourth arch artery is giving rise to the arch of aorta, and the subclavian artery. Arch of aorta on the left side and right subclavian artery, that is from fourth arch. Fifth arch artery goes nothing. Fifth arch artery, there's nothing. And sixth arch artery forms the pulmonary artery. The proximal part forms the pulmonary artery, and the distal part, it contributes to the ligamentum arteriosum. That is ligamentum arteriosum. Sir, maze yaar. Maze lo tum. Okay. So, right, this was pharyngeal arch arteries. Kya mushkil hai yaar? That's easy peasy, Japanesey. So, this is about the arterial arch, artery and development. Chalo sir. Now, from this arterial development, let me take you to the venous development here. We're going on time, no worries. So, take a deep breath. Try to absorb whatever is coming your way. I know whether it's my subject or any other subject in these one-shot program, it goes very fast. It goes like there's too much of content to be discussed in a very short amount of time. But you know, this is what we asked for. So let's take it nice and easy. I hope you understood it, because when you see this slide, when you see this PDF, and which I'll share with you, just by looking at the picture, you can easily make out, okay, what is coming from where. Just do one favor, guys. Please make sure that you revise everything tonight only. Don't even leave it for tomorrow. आज सोने से पहले कर डालना है इसको. बस एक बार just go through this PDF and you're done with it. Thank you, Ghosh. Chalo sir, let's come to the venous development. I need more attention from your side here. So venous development, people find it, venous development, guys. Okay. I should not be looking at to the Telegram here, because I know people will be watching this video even after we are done with this live session here. So they will be like that, whom am I talking to? But yeah, doesn't matter why they are not watching it live. They should watch it live. चलो सर, देखो बेटा, venous development in the embryo we have a vein called as a common cardinal vein. In the embryonic life, there is no superior inferior vena cava. So we have an anterior cardinal vein. The vein which is carrying the blood from above is anterior cardinal vein. The one which will carry from below is a posterior cardinal vein. Anterior cardinal, posterior cardinal. Right anterior cardinal vein, right posterior cardinal vein, both will join and form common cardinal. Left anterior cardinal, left posterior cardinal join together to form common cardinal vein. There we go. I hope this makes sense. Look at these arrows here. I hope these arrows will tell you that, okay, how the blood is coming here. That's a right side system, that's a left side system. Just to make it easy, I'm not writing right and left. You are smart enough to understand that. Look, the vein which is coming from above, those are what? Anterior cardinal vein, and the one coming from below are posterior cardinal vein. That is the right side system, and that same left side system is there, and they together form the vein called as a common cardinal vein. The right common cardinal vein and the left common cardinal vein. This is the initial type of venous system that we have, and that is not enough. We need more veins to develop because other organs are also developing simultaneously. Kidney ban raha hai, gonads ban rahe hain, suprarenal gland. There's so many things which are developing, so we need more veins, guys. So with the developing kidney, well, these are the kidney, let's developing kidney here, and these veins that you see come like which are attached to kidney, these small veins over there, their embryological name is a mesonephric vein. Abhi renal vein nahi bolna inko. These are mesonephric vein. That's a right mesonephric vein. This is a left mesonephric vein. So now this posterior cardinal vein, guys, which is going above here, it is like, okay, I need to take the blood from kidney also. So it will just take the blood from the kidney and then join back to the respective posterior cardinal vein. It's like you have you're going from point A to point B and you're hungry and there is no restaurant there. So obviously what will take? You'll take a detour. You just eat at the restaurant and join back to the main highway only. This is exactly what is being done, guys. These veins are collecting the blood from developing kidneys and they join back to the main highway only, that is posterior cardinal vein. This vein is called as a subcardinal vein. Names are important. The subcardinal vein, that is right subcardinal vein, and this is a left subcardinal vein here. Subcardinal. So subcardinal veins are the one which are taking the blood from the developing kidneys. Then we have another set of vein. Before subcardinal vein are collecting the blood from right and left developing kidneys. Not only that, there will be anastomosis between the subcardinal vein, and that is called as intersubcardinal anastomosis. Look at that anastomosis. There is a intersubcardinal anastomosis. And guys, this is intersubcardinal anastomosis. And there is another set of vein that you will see also coming like this and collecting the blood and going back from the other viscera also. That is called as a supracardinal vein. The another vein is also developing there. That is what? The supra. Look at that. So the same thing. Going away and then coming back to the same main highway only. This vein is called as a supracardinal vein, guys. This is called a supracardinal vein. I hope whatever vein you're looking at in this picture, you are able to visualize them here. You have an anterior cardinal vein coming from above, posterior cardinal vein coming from below. Then kidneys start developing. Then we have vein collecting the blood from developing kidneys joined with the posterior cardinal vein only, that is subcardinal vein. And we have an additional vein over there called as supracardinal vein also doing the same. Okay. Now again, let me take this picture. Please remember these names, guys, because I'm not gonna, in the next picture, I'll get rid of all these labelings here. And just like the arterial development, let me just make it faded so that we can look at the major veins here. Look at this picture. You're already oriented to this image. Now I need to move aside a little. Okay. Upar se shuru karte, guys. Let's start from above. Now what you see here, in the development of the first, let's start with the superior vena cava. Abhi superior vena cava is a combination of the right brachiocephalic and left brachiocephalic. Now be it superior vena cava or inferior vena cava, they are formed on what side only? The right side. So obviously whether it's a superior vena cava formation or inferior vena cava formation, our main focus will be toward the right side. Guys, look at the vein which is now being highlighted over there. That vein is carrying the blood from the head and neck region from above. So that is brachiocephalic vein. Now this brachiocephalic, if I consider this as a brachiocephalic vein, that is going toward the left side. I want the brachiocephalic vein to take the blood toward the right side only. So there is a formation of anastomosis called as an oblique anastomosis. Look at that here. So it is not wrong to say that right brachiocephalic vein is this one, that is a right brachiocephalic vein. And this one here is a left brachiocephalic vein. So right brachiocephalic vein is by the right anterior cardinal vein, that one. And left brachiocephalic vein is a small part by left anterior cardinal vein. And this anastomosis is called as an oblique anastomosis. That is called as an oblique anastomosis. Oblique anastomosis. And obviously, when the two brachiocephalic veins will join with each other, they will give rise to superior vena cava. Look at that, guys. That one and that one, these two are superior vena cava. So superior vena cava is derived from where? It is by the right anterior cardinal vein and also by the right common cardinal vein. Right anterior cardinal, small part of right anterior cardinal, and right common cardinal vein, that is a superior vena cava. So one problem sorted. We got both the brachiocephalic vein and we also got the superior vena cava. Okay. Now let's focus below here. Inferior vena cava banana, guys. Inferior vena cava. Now it is like a puzzle only, that where is inferior vena cava in this here. Inferior vena cava will be formed from only, again, on the left side only. It is formed by, now look at my finger and look at this highlighter coming right now. This is the right side posterior cardinal vein. This one here, that is supracardinal vein. There will be anastomosis. There will be subcardinal vein. And there is a hepatocardiac channel, which I'm not writing because that's not important from the exam point of view. We need to be a little exam oriented here. So this, whatever I highlighted over there, guys, this is inferior vena cava. Before the labeling comes over there, I want to just say this to yourself, guys. What are the things which are giving rise to inferior vena cava? What are the things that you marked over there? This is the posterior cardinal vein of the right side, right posterior cardinal vein, right supracardinal vein, that is supracardinal vein. This is anastomosis, like you don't have to mention that, but there is obviously anastomosis there. And then we have the main thing is a right subcardinal vein. That is a right subcardinal vein, which will join with the hepatocardiac channel. That part is not very important. So the main four component of the inferior vena cava, if I write, just I want you to please check that out. Right PCV, right posterior cardinal vein, right supracardinal vein, right subcardinal vein, anastomosis there, and then obviously right subcardinal vein. These are the component of inferior vena cava. And in the major vessel, the thing is, the moment you get the inferior vena cava or artery or main artery or main vein, then it's very easy to find out the tributaries. Abhinay, you start visualizing, guys. Obviously, when we talk about the kidney, look at this. Let me just make this area dark here. So guys, that is a right mesonephric vein. I'm pointing my finger at that is a right mesonephric vein. So right mesonephric vein is alone from what? Right renal vein. But left mesonephric vein, and also we need what? Intersubcardinal anastomosis. That forms the left renal vein, and that's why the left renal vein is longer also. When you look, obviously your IVC is toward the right side. So right renal vein is shorter and left renal vein is longer. The reason is in front of you. Because right renal vein is just by the right mesonephric, and the left renal vein is by the left mesonephric and mainly by the intersubcardinal anastomosis, which is make it longer. Okay. Now the vein which connects the superior vena cava and inferior vena cava, this is last year NEET image-based question, guys, cadaveric image-based question. It was about the azygous vein. Azygous vein connects the superior and the inferior vena cava. Now I'll tell you, this is a superior vena cava in this picture. This is inferior vena cava here. The one common mistake which people does, and I want all of you to be very careful about that, guys. This is not azygous vein. Look at my finger. This is not azygous vein. Azygous vein job is to connect superior and the inferior vena cava, but ये azygous vein नहीं है. Azygous vein is this one. This is the azygous vein. That means azygous vein is formed by a small part is by the posterior cardinal vein, but the major part is by the supracardinal vein. Look at that's a supracardinal vein here. That's the right supracardinal vein. So generally they don't give two options or three options to choose from. It is like one main option you have to choose here. So you'll say right side supracardinal vein forms azygous vein, as the job of azygous vein is to connect the superior and the inferior vena cava. This part will vanish, guys. This will be gone. So look at this. Does it make sense? Azygous vein is by the right supracardinal vein. That mainly is the right supracardinal vein, and some contribution by right posterior cardinal vein also. That is azygous vein. A very recent question only. Okay. Then, okay, guys, just think about the vein on the right side and left side, which are draining into IVC and renal vein. Same story below and the same story above. Gonadal vein, right gonadal vein and left gonadal vein. Guys, right gonadal vein goes into IVC and left gonadal vein goes into the renal vein. So that tells you that, there we go. Look at that. These are gonads. Also, the gonads are almost the size of the kidney only. So I'm sorry for that inappropriate size. So this is the caudal part of the subcardinal vein that is giving rise to what? The gonadal vein, whether it's a testicular vein or ovarian vein, guys, that is derived from the caudal part of the subcardinal vein. And Suprarenal vein. Adrenal gland will be formed. Adrenal gland will drain on the left side into the renal vein and again on the right side into inferior vena cava. So it's not wrong to say that I'm so sorry. I don't know why I said that. So adrenal vein is derived from the cranial part of the subcardinal vein. Cranial part of subcardinal vein. Just मौका चाहिए, जरा सा मौका चाहिए, जैसे ऐसे एकदम से गायब हो जाता है सब उधर से. Come back. वापस आते हैं. Caudal part of subcardinal vein forms the gonadal vein, and the cranial part of subcardinal vein, it forms the adrenal vein or suprarenal vein here, right? So, and that also justifies, that also tells you that why the right side adrenal vein and right gonadal vein goes into inferior vena cava, and left gonadal vein and left adrenal vein goes into the renal vein. The answer is in front of you, right? Just check out the text for that. Gonadal vein by the caudal part, and adrenal vein is by the cranial part of subcardinal vein. And again, let's shoo away other veins here so that we can see exactly how this thing look like here. There we go. So that is about the development of the venous system here. And you know, once you understand the normal development, you will not have a difficulty with anomaly. You can understand, whatever is giving rise to inferior vena cava on this side, if the same thing will persist on the left side, that will give rise to left IVC. If that oblique anastomosis is not formed, there will be left SVC. So the normal development is very important to understand, because then only the abnormal development can be understood here. So this is about the venous development. Need a little feedback from you once again, guys, how the venous development was. I hope you like that. These animations this kind of help you to revise it a little faster. My regular batch students, they know how much I made them draw in the class, everything, and then made them color and everything. But this, for the revision sake, I think that's easier. Thank you. Thank you for all these lovely emoticons. I don't know where you get this from. Paisa vasool. Chalo sir. Let's keep going. So after the venous development, let's come to another part where it is about I'm going to read every message that you're sending, right? Like I'll just scroll back to the very first message where I said, okay, I'm starting, and then I'm gonna go and gonna scroll every single all these topics, and we'll find out that what all lovely messages you're writing, and obviously we'll find out your queries also in between. So it's not that I'm just looking for those messages only. Chalo guys. So from the venous development, arterial development. So it's we're done with the main thing about the pharyngeal arches. We talked about the pharyngeal arch arteries. We talked about the venous system. Now let's talk about the mesogastrium, dorsal and the ventral mesogastrium, guys. Dorsal and the ventral mesogastrium. Okay. See, what is the story about the ventral and dorsal mesogastrium, guys? If you look at the stomach, because stomach is the only viscera which is having a peritoneal fold in front also and behind also. Otherwise, if you see beyond, I mean, if you look at the intestine, if you look at the colon, the mesentery is only present at the back here. But in case of the developing stomach, gastrium, we have a dorsal mesogastrium. That's everything that you see behind stomach, that is dorsal mesogastrium, and everything that you see in front, that is a ventral mesogastrium. Abhi, ventral mesogastrium will give rise to what? You just have to think about lesser curvature of stomach, liver, anterior abdominal wall. Whatever ligament you can think of, kuch ratna nahi hai. There is no rot learning in this. It's just a simple concept only, guys. Lesser omentum is connecting the stomach to liver. So that means lesser omentum is derived from the ventral mesogastrium. Liver is connected to anterior abdominal wall by falciform ligament, also from the ventral mesogastrium. And liver itself is surrounded by the ligaments called as the coronary ligaments and triangular ligaments. They're also derivatives of ventral mesogastrium. Falciform ligament was the image-based question asked in the NEET, but any other ligament they can ask you, doesn't matter. So whether it is lesser omentum, whether it is a ligament of the liver which is surrounding it, or whether it is a falciform ligament, they're all derivatives of the ventral mesogastrium. Then dorsal mesogastrium, guys. Dorsal mesogastrium will give rise to what? Dorsal mesogastrium may, you think about the greater curvature. You have to make up your mind that what I'm looking at. I'm thinking about the greater curvature of stomach. Abhi greater curvature of stomach, the fundus part is connected to diaphragm. That's a gastrophrenic ligament. Stomach and spleen are connected by gastrosplenic ligament. Spleen and kidney on the posterior wall are connected by lenorenal or splenorenal ligament. And then obviously on the greater curvature, what momentum will be there? The greater momentum. So obviously all these are derivatives of what? The dorsal mesogastrium. So dorsal mesogastrium derivatives are gastrophrenic, gastrosplenic, lenorenal, greater momentum. All these are derivatives of dorsal mesogastrium. So it's a very simple and basic concept that we need to see, that ventral mesogastrium, it's all about lesser curvature. Say you have to go toward the abdominal wall, anterior abdominal wall. And for the greater dorsal mesogastrium, think about the greater curvature and just go backward. Whatever ligament you'll find in your pathway, every ligament is derived from the dorsal mesogastrium. And again, that's not a terminal question, guys. They've already asked a falciform ligament and image-based question. I have a very, very strong gut feeling for this. They will ask you something else. Again, they give you an image, they put an arrow on maybe lesser momentum, maybe greater momentum, something, and they will ask you, okay, where it is derived from. So it's a question which is not ending just by the falciform ligament only. And I generally look at the questions that way only. In anatomy, there is nothing new to ask. Abhi tuberculosis ka treatment to hai nahi, it will keep on changing every 6 months. So in anatomy, what new they will ask you is, they will just keep on formulating the question from the same topic only, but the examiner is very smart to formulate new questions every time. But I always say these are very predictable, guys. When you're looking at PYQ, just knowing the answer to PYQ is not enough. Everyone is reading PYQ. Yaar, sabko aate PYQ ke answer. That's no big deal here. The point is how much you can extract out of that topic. How much, no matter how much the examiner tries to give you an image-based question on that or clinical question on that topic which is already asked here, मैं उसको miss नहीं करूँगा. I'm not going to miss out on that part. And this is the way of looking at the PYQs only. Just not reading all these long explanation given the GTs. That is not enough here, because sometimes I see there's a very, very long explanation given on some questions here, but I don't find it useful here. I need to look at, okay, what is that question? What is the answer? What is the important topic over there mentioned here? And then I need to read it from somewhere else, not from any of the explanation given in GTs. Chali sir. No, beta, not bile duct. Bile duct is not derived. Bile duct is derived from foregut only. It is the extension from the foregut itself. Bile duct is an endodermal structure. Mesogastriums are all mesodermal. So one last thing in the embryology part, and that is the genital ducts development here. Let me take you back to the very first slide when we said intermediate mesoderm. We talked about paraxial mesoderm, we talked about lateral plate mesoderm, but we did not talk about the intermediate mesoderm, guys. Intermediate, everything that you're looking at over there here, intermediate mesoderm only. This yellow colored structure over there, that is a urogenital sinus coming from cloaca. And whatever this blue, red, orange, and gray that is shown over there, that is all intermediate mesoderm, guys. Intermediate mesoderm will give rise to genital ridge, that is genital ridge over there, which will give rise to gonads, testis and ovary. And it will give rise to the two ducts over there, that is mesonephric duct and paramesonephric duct. The mesonephric and paramesonephric duct. Moonlight beta, hepatogastric ligament and hepatoduodenal ligament is just a name of lesser momentum only. No, naam socho na, why this again not learning. Hepatogastric, liver se stomach, and hepatoduodenal, from liver to duodenum, that's lesser momentum only. The two parts of lesser momentum is called as the hepatogastric and hepatoduodenal ligament. So that is nothing new that you mentioned there. Okay, so intermediate mesoderm is having mesonephric and paramesonephric. Let's say if this is an image-based question, it's pretty simple. The duct which is more outside, it's para. जो परे है, that is paramesonephric duct, and the one which is more inside, that is mesonephric duct. So the duct that you see which is close to the gonads, developing gonads के जो पास में है, that is a mesonephric duct, the red one over there, and the blue one is a paramesonephric duct. Though eventually the paramesonephric duct will come and join with each other, and then they invade the urogenital sinus. If you notice one thing, mesonephric duct, guys, all of you look at the red color over there. Mesonephric duct is entering into the urogenital sinus individually. Right one separate, left one separate. Paramesonephric duct of both the side will come, eventually will fuse, and then they invade the urogenital sinus from posterior side. Mesonephric duct, also called as the Wolffian duct, it is a duct for both male and female. I mean, it is required equally for both male and female, because mesonephric duct will give rise to what, guys? Number one, it will give rise to the posterior wall of urethra, posterior wall of prostatic urethra in male, and posterior wall of urethra in female also. Trigone in male, trigone in female, and the ureteric bud derivatives and trigone. See, ureteric, what is ureteric bud derivatives? The collecting portion of kidney. All the collecting portion of kidney, the collecting duct, renal papillae, major minor calyces, ureter, all these is coming from ureteric bud, or ureteric bud खुद किससे आता है? Mesonephric duct से. So look at this here. Till now, what you're seeing, that mesonephric duct has almost equal role to play both in male and female. Forming the urethra also, forming the ureteric bud also, trigone also, same here. But from this point onwards, the mesonephric duct is main duct for male, because it will give rise to the spermatic pathway, the vas deferens, ejaculated duct, epididymis, and even appendix of epididymis also, which is a remnant only. So spermatic pathway and appendix of epididymis, that is coming from the, in the male, that is from the mesonephric duct here. Whereas in case of female, we only remnant is present, and that remnant in the female is called as a Gartner's duct, also called as a duct of Epiphoron. So Gartner's duct, guys, Gartner's duct hai, Gartner's cyst nahi, and Gartner's duct is located in broad ligament here. I always emphasize in this question because when you ask any intern or post-intern about the Gartner's duct, they start thinking about Gartner's cyst. Gartner's cyst is present in the upper vaginal wall. Gartner's duct is present in the broad ligament. Don't forget that Gartner's duct is in the broad ligament. I hope that flashing light just stays in your brain. I don't drink beer. Paramesonephric duct, guys. Paramesonephric duct for male and female. If you look at the paramesonephric duct for female, it is a main duct because it is giving rise to the, like you can make out with the shape also, it will give rise to fallopian tube, it will give rise to the uterus, fundus of the uterus, the body of uterus, cervix, and upper part of vagina also. So paramesonephric is main for female, fallopian tube, uterus and upper vaginal wall, that is in female. Male में खाली only remnants are there, guys. In male only remnants, that is a prostatic utricle, which is a blind opening present on the prostatic urethra, and appendix of testis. This is appendix of epididymis, guys. This is appendix of testis we are talking about, appendix of testis. This is about the mesonephric and the paramesonephric duct. So guys, this is about the embryology part. So that's the major embryo chunk. Obviously, yaar, one shot hai, to aisa to nahi ki we are going to everything here. But I hope that I'm able to kind of revise the major chunk on the important part of the embryology from you, from where the most likely the questions are asked from there. Okay. Yes. Water. There's nothing like water. As I said, the histology will come in between like some injections only. So thoda histo kar lete, guys. Let's take a couple of slides in the let's discuss a couple of slides of the histology also simultaneously, guys. Now I'm going to show you a couple of slides here, like cardiac muscle and the skeletal muscle. Both basic slides हैं, but यार exam में पूछते हैं, तो obviously we should be knowing about them. Now if you look at this picture of the cardiac muscle, now what you're looking at here, guys, cardiac muscle, the one thing about is the branching. When you look at the next slide, which is of skeletal muscle, they are parallel bundles here, but the cardiac muscles, they are profoundly branched. They're like a lot of branches there. And if I just take out a small portion of this cardiac muscle, and if you look carefully here, what you'll notice in the cardiac muscle is that we have the nucleus, we can see oval and round nucleus present somewhere in the center. Like, unlike the skeletal muscle where the nuclear peripheral and the flat nuclei, we have more of a like centrally placed nuclei, the single nuclei there. It's not multinucleated like in case of the skeletal muscle. And the most important thing in the cardiac muscle is the intercalated disc here. Now, if you look at this picture only, you can see one intercalated disc over there. You can see one over there. Oh, my hand is being cut over there. I'm going out of the frame. So, like, look at the picture here. Look at this pointers, the arrows over there. They are pointing at the intercalated disc. And intercalated disc are the one which are actually the functional syncytium here. The type of junctional complex which are present at the intercalated disc, we have like zona adherences there. We got gap junctions, we got desmosomes. These are the type of junctional complex which are present at the intercalated disc. And guys, this gap junction, it's very important because gap junction is the one which permits the ionic traffic and which from one cell to another cell. And that provides the functional syncytium. That's how obviously the ions from one cell move to another cell. That is because of the gap junction only. We say na intercalated disc is a functional syncytium, and that is because of these gap junctions only. And then the desmosomes are the one which are the anchoring filament. They are the one which are anchoring the two cells with each other here. That is the desmosome which anchors the end to end of the cardiac fibers here. इस पे question ये पूछते हैं in the cardiac muscle that okay, which type of junctional complexes is seen or not seen that way here. So zona adherens is there, the adherent junction, the gap junction, and the desmosome is seen there. If you compare it to the skeletal muscle, guys, skeletal muscle, देखो, it's quite clear. First of all, look at the parallel bundles. No branching there. It's a parallel bundle that you can see in the skeletal muscle. And secondly, if you look at the nuclei are flat and peripheral nucleus. There are a lot of cross striations also. You can all see all these cross striations are there here. You must have read about these striations in your physiology class also, that the actin and myosin filaments are there. A band, H zones are there. So these are all cross striations, and look at the nuclei, the way the nuclei are present, they are all peripheral and flat nuclei. There's multinucleated. You can see multiple nuclei are present over there. They're multinucleated, and we have a flat and peripheral nuclei in case of the skeletal muscle. Chalo, it was just a double dose of the histology in here. I'll keep on injecting slides in between here. Chale, moving on. Histology becomes a little monotonous, and we have to keep talking about that. That's why I just kept in between. Guys, let's start with our next unit here, and we now gonna start with the upper limb here. Now, upper limb, what makes the upper limb important? One, hand will make it very, very important, and the nerve and nerve injuries. When it comes to the clinical question, upper limb is far more important than lower limb when it comes to the nerve injuries question, guys. Okay, so without a further ado, let me just start with some important muscles here. Now, scapulohumeral muscle. Not every muscle is important. There's some muscle which I'm going to discuss with you, and along with their action also. Guys, understand, and this is something which people ask me a lot, that sir, which muscle is to be read? There's so many muscles present in the upper limb, lower limb, head and neck. I'm not going to read those 700 muscles in the human body. Obviously, you need to look at the muscles. And if you're looking at a long bone, especially long bone I'm talking about, femur and humerus. The upper end of the humerus and upper end of the femur, according to me, are the two most important side for the muscle attachment questions to be asked. Look at the history of PGMA examination, guys. First of all, you will not find a question asked on the origin. Ab check karna, you will not find a question on the origin. It's always an insertion they will ask you, because the muscle is going to make a movement at the insertion point. And insertions are usually at the upper end of a long bone, whether it's the upper end of tibia, upper end of the femur, upper end of radius ulna, upper end of the humerus, and upper end of humerus and upper end of femur in that category, in that list, becomes the most important. What you're looking at right now, you're looking at the lesser tubercle, which is present in the front here. That is a lesser tubercle. There is a lesser tubercle, and there's a muscle attachment over there. There's a subscapularis muscle. There's a muscle coming from the front of the scapula. That is subscapularis muscle, and that attaches there. Then look at this. This is the bicipital groove. Bicipital groove will give passage to the long head of the biceps, and there are three muscles which are attached over there, which is a lady between two major, right? You know that lady between two major. The lady here is what? Latissimus dorsi, and the two major is pectoralis major and teres major. That is a lady, that is latissimus dorsi, and the two major, pectoralis major is more lateral and teres major is more medially placed here. That is medial to lateral. You're looking at the lateral to medial. That is the three muscle over there. And when you look at the what do you say, the muscle mode? One thing, why I'm discussing these muscles together? Subscapularis muscle is on the lesser tubercle, and then we have the three muscle here. And look at all these muscles have different origin, guys. One of the muscle coming from the anterior surface of scapula. Pectoralis major will come from the anterior surface of the chest wall. Latissimus dorsi तो पीछे से आ रहा है, back से आ रहा है. Teres major is coming from the lateral border of scapula. All different origin, but all the muscles are inserted in front of the humerus. Like, doesn't matter the muscle is coming from the front from here, or even if it is coming from back, but ultimately they're coming in the front of the humerus. So all these muscles, they pull the arm inward and rotate inward like this. So adduction and internal rotation is their common function. Whatever muscle you're looking at right now, guys, their common action is adduction and internal rotation. They all help in adduction and internal rotation. What about the lateral side? That is that tubercle over there is a greater tubercle, guys. Greater tubercle or greater, like in the femur we have greater trochanter. That's a greater tubercle. Abhi greater tubercle is giving passage or insertion of three muscles. That is sit muscles, SIT. That is supraspinatus, infraspinatus, and teres minor. Subscapularis is coming from the front, so it is an internal rotator. Supraspinatus comes from above, so it is an initiator of abduction. And teres minor and infraspinatus पीछे से आते हैं. They come from posterior side, so they are external rotator. Muscle सामने है, internal rotator. If the muscle is coming from back, that is external rotator. If it is present on the top of the joint here, it is just helping in the initiation of abduction. So guys, supraspinatus is for the 0 to 15 degree of abduction. Initiation of abduction is by supraspinatus, whereas infraspinatus and teres minor muscle both are responsible for external rotation. They will also help in adduction to an extent, but main action is the external rotation. Adduction, any muscle which is running horizontally will help in adduction, guys. Doesn't matter it is present in front or behind. So adduction तो सामने वाला muscle भी कर रहा है, पीछे वाला muscle भी कर रहा है. But what is different is the muscle present in front is causing internal rotation, and the muscle coming from posterior side to greater tubercle will cause external rotation. Vertebroscapular muscle, one of the recent question again, last year question only. Now the three muscle that you see which is inserted, we just talked about these muscle. We saw that supraspinatus is there, that is infraspinatus there, and that is teres minor, and that's a greater tubercle, guys. It's just that you're looking at the greater tubercle from posterior side. So supraspinatus, look at my finger over there, supraspinatus inserting there. That is infraspinatus. The whole muscle is this big muscle is infraspinatus only here, this one, and that is a teres minor muscle. and all of them are inserted on the greater tubercle. Now let's focus onto the muscle coming from the vertebral column to the scapula, the vertebroscapular muscle. We have a levator scapulae, number one. We got rhomboideus minor, and then look at this big muscle, which was actually the image-based question, that is rhomboideus major. The one common thing about these three muscles is, be it rhomboideus minor, major, or levator scapulae, there is a nerve which is running along them and supplying all three of them. That is called as the dorsal scapular nerve, coming from the root of the brachial plexus. C5 root of the brachial plexus, the dorsal scapular nerve will supply all three of them. Levator scapulae, naam hi bata raha guys, levator scapulae is for the elevation of scapula. Rhomboideus minor and major will help in what? Retraction. And when they retract, now look at this, and understand with this fiber here, when the levator scapula, this rhomboideus minor and major, they will retract the scapula, they will take the medial border of scapula upward and medially, so glenoid cavity will be rotated downward. The question asked in the exam was about the glenoid cavity. What will be the direction of the glenoid cavity when the rhomboideus major will contract? So it will rotate the glenoid cavity downwards. Retraction of scapula and rotation of the glenoid cavity downward is the glenoid fossa, glenoid cavity downward. That is a function of rhomboideus minor and major. So they're pulling the scapula upward and medially, and glenoid cavity is turning downward. Okay. Then coming to some of the important, the humeral fractures and nerve injuries. What are the nerves which are vulnerable to injury in the different end level of the humerus, guys? If you look at the surgical neck of the humerus, the nerve which is passing behind the surgical neck of the humerus is axillary nerve. So the surgical neck of the humerus fracture, then obviously axillary nerve is most likely to injured. The nerve which is passing from the spiral groove, the nerve passing from spiral groove is what? That is radial nerve. So any mid-shaft fracture which is passing through spiral groove, radial nerve is most likely to get involved in that. If it is a supracondylar fracture, now this is some people get it wrong at times here. In supracondylar fracture, it's the anterior interosseous nerve which is most commonly involved. Anterior interosseous nerve is a nerve present in the forearm, and it's a branch of the median nerve. Anterior interosseous nerve is the one which is most commonly involved in the supracondylar fracture. Actually, that's a fibrous band which is connected to anterior interosseous nerve. In the supracondylar fracture, that fragment rotates backward. The band pulls the anterior interosseous nerve. So, both indirect injury hai, but if the question is asked, what is the most common nerve to be involved? So, it's an anterior interosseous nerve, branch of median nerve. Both median nerve and anterior interosseous nerve are given in the option. Go with anterior interosseous nerve, guys. Medial epicondylar fracture, no surprises there. It's the ulnar nerve. Ulnar nerve is present behind the medial epicondyle. So that is a nerve most commonly involved. In fact, even in the lateral epicondylar fracture, again, it's the ulnar nerve which is most likely to get involved and not the radial nerve, because tardy ulnar nerve palsy. When there is a the lateral epicondylar fracture, what will happen? There is a cubitus valgus, guys. There's a valgus deformity. Now, if this angle will increase on this side, so there is a stretch on the medial side, and again, ulnar nerve will get affected. Medial epicondylar fracture में direct injury to ulnar nerve, no doubt about that. Lateral epicondylar fracture में it's a cubitus valgus, and that stretch to the ulnar nerve causes the tardy ulnar nerve palsy. The cubitus valgus deformity called tardy ulnar nerve palsy. Chalo, moving on from this to the main point, that is the hand, guys. This is something we have to discuss in detail about the muscles of the hand. Okay, here we go. Hand muscles, the thenar and hypothenars first. Dekho, when it comes, this is a very commonly asked image-based question. Now, first let me give an orientation of this, how this slide is going to come to you. I'm going to use the red color for the ulnar nerve and blue color for median nerve. That this is going to be universal color in the next 3-4 slides. So ulnar nerve will be showing with the red and median nerve with the blue, just to show you that what muscle is supplied by what here. These are thenar muscles here. On the other side, these are hypothenar muscles, and then lumbricals are also visible in that here. Okay, what muscle is visible? The muscle which is visible very much outside here, that is abductor pollicis brevis, pollicis of the thumb, abductor pollicis brevis, and we have a muscle which is more inside, that is a flexor pollicis brevis. Unless we remove these two muscles, I will not be able to see the muscle opponens pollicis. So opponens pollicis is not visible now, guys. So abductor pollicis brevis and flexor pollicis brevis is visible. Opponens pollicis is present more deep to that here. So image-based question में don't expect to get the opponent's pollicis, because they have to remove these muscle and then this picture become very distorted here. So in the image-based question, it is going to be this image. It is going to be this image, guys. So they will be asking you the muscle which are visible right now to you. So abductor and flexor pollicis brevis. And look at that, and look at, I'm drawing with the blue color over there, they're supplied a median nerve. And there is one odd muscle here that is called as adductor pollicis, and adductor pollicis supplied by the ulnar nerve. Actually, ulnar nerve will come from medial side like this, will make an arch like this, and ultimately ends by supplying adductor pollicis. It is the last muscle to be supplied by the ulnar nerve, also called as a graveyard of the ulnar nerve. So adductor pollicis. Adductor pollicis muscle is very, very important. The reason being, guys, if let's say if I remove these tendons, now you're able to see the entire adductor pollicis. All these long tendons are being removed. All these flexor digitorum superficialis and profundus tendons are removed. And now I can see adductor pollicis muscle completely. Coming from the shaft of third metacarpal, running very much horizontally. It's a big, big muscle over there. And obviously you need a very strong adductor, guys. To hold the objects in between your palm and the thumb, you need a very strong adductor here. Let's say if I want to hold the case here. So obviously, if let's say if I'm trying to pull this away from my hand and I need to hold this here. So I need a very strong adductor pollicis muscle here. Look, all the fingers are working on the other side and thumb is working opposite to them. So I need a strong adductor pollicis muscle there. But let's say if the ulnar nerve is injured and adductor pollicis is not working. So what the patient will do, they will curl the thumb like this to try to do a trick movement here. Because the adductor pollicis is not working. So now they're curling the thumb and using the interphalangeal joint to try to hold the object in between. And this is called as the book test which is done, and this sign is called as a Froment sign. When you see a patient curling his thumb to hold the object between the radial side of the hand and this thumb, that is a Froment sign, guys. That is a Froment sign. It is seen in the book test here, right? It's a book test for the ulnar nerve palsy, and the Froment sign, you will see the thumb is being curled. Yeah. Okay. If I look at the other side here, this was an abductor, this was a flexor. The same story on the other side, guys. The muscle which is more outside is abductor digiti minimi, and that is flexor digiti minimi. Ulnar nerve obviously is the main nerve supplying them here. So as of now, out of the 4 thenars and 4 hypothenars, opponents to nahi dikhai dega. So forget about opponent's pollicis muscle because that is not visible unless you remove these muscles there. Adductor pollicis muscle is another important muscle you need to remember. So abductor, flexor, abductor, flexor, and one strong adductor of thumb, that is adductor pollicis. Coming to the second group of muscle, that is lumbricals. The property of lumbricals, whether the lumbricals are present in the hand, that's why yeah, Eklavya has to he need to shot the arrows with the thumb at least. Initially we have to use the thumb to mark those OMR sheets. Now, if you have to mark answers, you can just do it by the foot also. I know this. So we don't need the thumb. So you can also give away your thumb to me. Chalo. Guys, long tendons, lumbricals. What's the property of lumbrical muscle? Whether lumbricals are present in hand or lumbricals are present in the foot, lumbricals are called as tendon to tendon muscle. They originate on tendon and they insert on tendon. That's the property of lumbrical. Whether hand or foot, lumbrical are tendon to tendon muscle. In the hand, they originate from the tendon of flexor digitorum profundus and they insert on the extensor digitorum tendon here. So flexor digitorum profundus se start hoga or extensor digitorum pe insert hoga. Now people often ask me, sir, we do get confused between the lumbricals and in between the interossei. Nahi yaar, chance hi nahi hai. You cannot get confused between the lumbricals and interossei. Lumbricals are originating from tendons. Unless you're looking at tendons, you cannot see lumbricals. And interossei, from the bones, unless you're looking at the metacarpals, how will you identify interossei? So lumbricals and interossei mein confusion hone ka chance hi nahi. There is no chance. Okay. 4 lumbricals are there. The first 2 lumbricals that you can see, this is first one, this is second one. These are unipinnate lumbricals. They're toward this side, lateral side. They're supplied by median nerve. The first and second unipinnate supplied by. Third and fourth lumbrical are bipinnate lumbricals and they are supplied by the ulnar nerves. So lumbricals are divided. Lumbricals are divided in median nerve and ulnar nerve. 2-2. बेटा इसका अंगूठा देना नहीं कहते, इसका अंगूठा दिखाना कहते हैं. Okay, चलो. Interossei, guys. Palmar interossei and dorsal interossei. Now, palmar interossei, all palmar interossei are unipinnate. All dorsal interossei bipinnate, guys. Palmar interossei, I'm sure you all know the rule pad and dab. Palmar interossei for adduction and dorsal interossei for abduction of fingers. Adduction karna is the palmar interossei, abduction karna dorsal interossei. Now, first of all, look at the palmar interossei. Palmar interossei are the one which are for adduction, and whether it is hand or it is foot, for the interossei muscles are supplied by the dominant nerve. The dominant nerve in hand is ulnar nerve. Similarly, dominant nerve in the foot is a lateral plantar nerve, and all interossei are supplied by the dominant nerve. Whether they are unipinnate, they are bipinnate, doesn't matter. So they're all supplied by the ulnar nerve. Okay. Now, middle finger is the one which is the principal digit. When we talk about the adduction and abduction in hand, middle finger is the main finger here. So middle finger is a principal digit there, as you can see. So as you can see, palmar interosseous job is adduction. So they are all pulling the fingers toward the middle finger. So the one finger which is not having a palmar interosseous middle only. When you do adduction, we are coming close to middle finger. We're not moving middle finger here. So we need palmar interosseous for these 4 fingers, but not for the middle finger. So guys, it's the middle finger which is devoid of the palmar interosseous. They're unipinnate, and middle finger is devoid of palmar interosseous, absent on the middle finger. Thumb may not have palmar interosseous. Thumb wala palmar interosseous, it may be or may not be present, because thumb ko palmar interosseous ka zarurat nahi hai guys. Palmar interosseous is for adduction. We already have a muscle called as adductor pollicis, and that's why we don't need a palmar interosseous for the thumb. So it may be present or it may not be present. So it's a variation which is very much possible, guys. Thumb palmar interosseous may not be present. And yes, right, the test which is done for the palmar interosseous is called as a card test. I always say that the picture given for the card test, most of the pictures are incorrect here. This is also not a correct image. Card test is done from the corresponding fingers here. If you're doing the card test between this middle finger and the index finger, then obviously you need to pull it from these 2 fingers only. अभी ऐसे thumb से खींचेंगे तो card निकल ही आएगा ना यार, फिर तो no matter who is holding the card. So card test is done. You should also be holding the card from the corresponding fingers only. ऐसे thumb से नहीं पकड़ के खींच लेना उसको. Dorsal interosseous, all dorsal interosseous are for abduction, all dorsal interosseous for abduction. Now look at this. First of all dorsal interosseous are bipinnate. If you look at the first, second, third, fourth, all are bipinnate. I don't need a dorsal interosseous for thumb. I don't need a dorsal interosseous for little finger, because my thumb and little finger is already having thenars and hypothenars, and they are causing abduction. So we have a muscle called as abductor pollicis. We have an abductor digiti minimi. So obviously they don't need it. So इनको अलग कर देते हैं. So now we have 4 dorsal interosseous attached to 3 fingers. The first one goes to index, the last one goes to ring, and the remaining 2 goes to middle finger. Now the middle finger, which was devoid of palmar interosseous, is having double dorsal interosseous. Palmar interosseous एक भी नहीं है, but dorsal interosseous are 2 in number. So they are bipinnate, number 1. And we said absent on thumb and little finger. There is no palmar dorsal interosseous on thumb and little finger. And middle finger is having second and third. Double dorsal interosseous is present on the middle finger. And yes, the test which is done for the dorsal interosseous is what? It is a Igawa test, guys. You ask the patient to place the hand on the plane surface, and you just ask him to move the middle finger in both the directions. That test is called as the Igawa test. Look at this here. That test is called as the Igawa test. The test is called as the Igawa test. नहीं बेटा, ऊपर वाले ने कुछ दिल खोल के नहीं दिया हुआ. The middle finger is having a double dorsal interosseous is not to show the middle finger to the world. It is actually the only muscle which is going to the middle finger is the dorsal interosseous only. So middle finger need to move in both the direction, and that is radial deviation and ulnar deviation, and that is done by the dorsal interosseous. Palmar interosseous है नहीं. So whatever movement you do for the middle finger, whether it's toward the lateral side or medial side, that is done by the dorsal interosseous only. Chalo. So I hope you understood this hand thing, guys. Thenar muscles, hypothenars, the lumbricals, the palmar interosseous, and the dorsal interosseous. But see, that's what I told you. You asking, what's you asked me the same question which I was trying to clarify you. You will not be seeing the interosseous and the lumbricals together. Lumbricals are coming from the tendon. So when the tendons are intact, you will not be able to see interosseous. And once you remove the tendon, lumbricals are gone. So only interosseous are visible here. So there is no a good quality specimen, agar chhod do alag baat hai, but there is no, I don't think they will give you a picture or that's a specimen in which the lumbricals and palmar and the dorsal interosseous are present together, and you have to differentiate between them, because you have to remove the tendon to see the interosseous muscle. Okay. So guys, 30 seconds break. तब तक मैं आपके मैसेज देखता हूँ क्या क्या लिख रहे हो. Okay. Break over. Chaliye sir. Next, moving on to the clavipectoral fascia. Again, a question which is asked repeatedly in the exam. How do I stay motivated? Look, everything is there in front of me to stay motivated. You people are there to keep me motivated all the time. What is there not to be motivated here? Tell me one thing which is not there to be motivated here. I am living dream life. ना I don't set any NEET PG exam or something. ये सब मत बोलो यार please. ऐसा कुछ नहीं. चलो come back guys. Clavipectoral fascia देखो. Clavipectoral fascia, the reason we call it a clavipectoral fascia because it is extending from the clavicle and it is covering the pectoral muscle. The two muscles which are enclosed in the clavipectoral fascia, one is the subclavius muscle which is just below the clavicle, and the next muscle which is present coming from third, fourth and fifth rib, that is the pectoralis minor muscle. So subclavius and pectoralis minor muscle, these are the two muscles which are enclosed in the clavipectoral fascia. The main question asked on the clavipectoral fascia is that what structures are piercing it, and structures piercing clavipectoral fascia mein we have one vein, one artery, one nerve, one lymphatic. Sab kuch one. It's all one. Vein you can already see guys. Look at the vein coming from the lateral side. That's a cephalic vein there. Artery is thoracoacromial artery. Nerve is lateral pectoral nerve which comes out to supply pectoralis major, and some lymphatics which drains into the apical lymph node are also there. So structure piercing clavipectoral fascia, cephalic vein going inside, lateral pectoral nerve comes outside. If I just go with that, lateral pectoral nerve bahar aayega to supply pectoralis major. Thoracoacromial artery will also come outside, piercing it and supplying the structures. And the two structures will go inside, that is cephalic vein will go in and the lymphatics will also go in here. So there are four structures which are piercing the clavipectoral fascia, two to come out and two to go in. Thank you guys. Thank you. I know that I have also put an effort in making all these slides and everything, but definitely it needs some more effort from your side because it's you who need to put in a brain right now. You need to remember the stuff. You need to kind of understand everything. And even despite after the class, I'll go back and I can relax after that here. But obviously you need to go back and again read this thing. You have to solve some questions from here and there. So I know it's more of your hard work in this here. But if I can be of any help, like if you're finding this presentation or this, this discussion fruitful, nothing will make me more happy. Chalo. And the one more thing about the clavipectoral fascia, that beyond the pectoralis minor muscle, it is extending as a ligament called a suspensory ligament of axilla, guys. When you touch your floor of axilla, you see there's a depression over there. It's not flat. The reason it is not flat, it is slightly dome shaped because the suspensory ligament of axilla is pulling it. The suspensory ligament of axilla is pulling it, and that is an extension of the clavipectoral fascia only. A little about brachial plexus and the injuries also. Now, what you're looking at right now, guys, it's a brachial plexus. We all know that brachial plexus is formed by the ventral primary rami of C5, C6, C7, C8 and T1. They are all forming the brachial plexus, C5 to T1. C5 and C6 root, look at that C5 and C6, roots of the brachial plexus comes out between scalenus anterior and scalenus medius, which we will see in the head and neck part. So, bhulna nahi isko. Anterior and scalenus medius. So, C5, C6 is forming the upper trunk, C7 forming the middle trunk, and C8 and T1 together forming the lower trunk, the three trunks of the brachial plexus. And after the trunk, if you see, go further, you can see upper trunk is giving a contribution toward the middle side. Lower trunk is also giving contribution to middle side, but middle one is returning the favor only to the upper one, and this is called the division part of the brachial plexus, and the only part of the brachial plexus which will not give any branches. I mean, they're branching with each other, but it is not giving any branches as such. I mean, there's no nerve coming out from the division part which is supplying any skin or muscle or anything like that here. And that was an INICT question, guys, that which portion of brachial plexus gives no branches, that is a division part. And then finally, we have a cords of the brachial plexus, and the nomenclature of the cords of brachial plexus is based on axillary artery. Lateral to axillary artery, lateral cord, posterior to axillary artery, posterior cord, medial to axillary artery, medial cord of brachial plexus. So the brachial plexus cords will be seen there. I can be very sure about that they will not be asking you that identify the branches of brachial plexus. Not happening, guys, and not happening at least in the next 5-10 years, I can tell you, unless they start giving very high definition images, jo nahi hone wala hai. But what they can ask you in image based question in brachial plexus, although this is still a little extreme question to be asked, but still they can ask you how this brachial plexus is ending. Lateral cord, posterior cord, medial cord, terminal branch they can ask you in the image based question. So that ways, if you look at this, the lateral cord branch, which looks like a continuation of the lateral cord, is a musculocutaneous nerve. That is a musculocutaneous nerve. Posterior cord will continue as the radial nerve, and medial cord will continue as the ulnar nerve. And then lateral cord and medial cord both together will give rise to the median nerve. Median nerve is formed by both lateral cord as well as medial cord. We have a lateral root of median nerve and we got a medial root of median nerve also. I'm going to have good time like reading all your comments after the class, but as I said, right now we need to stay on track. So guys, this is just a formation of the brachial plexus. The division gives no branches, and if you ask me personally, my suggestion is that look at the terminal part of the brachial plexus and try to identify these nerves: musculocutaneous, radial nerve, median nerve, and ulnar nerve. The two injuries of the brachial plexus, the one which is affecting the upper trunk and the one which is affecting the lower trunk, the Erb's palsy and the Klumpke's palsy, we all know that. Now in the Erb's palsy, the injuries to the upper trunk, so obviously the root value which is affected in the Erb's palsy is C5 and C6, because upper trunk is formed by C5 and C6 here. Upper trunk root value is C5 and C6. And C5 and C6 is a major component of the axillary nerve, which is supplying deltoid muscle, and musculocutaneous nerve supplying the biceps and brachialis and coracobrachialis. But if I just take the important one, axillary nerve, that is supplying deltoid, musculocutaneous nerve supplying biceps. Let's just take the important one. Agar aapka deltoid is gone, guys, deltoid is gone, so your shoulder will come into adducted position. And if your bicep muscle is not working, your elbow will come into extended position. And I hope you know that bicep is a very strong supinator also. Bicep is also for the supination also, guys. Supination movement is by the bicep brachii. Agar bicep nahi kaam karega, to your forearm will go into pronated position as well. So your arm is adducted, your elbow is extended, and obviously your forearm is pronated like this, and you know that is called as a policeman's tip hand. Adducted shoulder, extended elbow, pronated forearm, and that is called as a policeman's tip hand. That is a policeman's tip hand. Policeman's tip hand or porter's tip hand or waiter's tip hand, various names are given to that. About the Klumpke's palsy, which is more of a stretch injury, guys. Hyperabduction or hyperextension can lead to that. In the Klumpke's palsy, the injury is to the lower trunk of the brachial plexus, and this time the root value affected is the C8 and T1. Klumpke's palsy mein root value is affected C8 and T1, lower trunk hai. And C8 and T1 is a major root value. It's a major root value for the ulnar nerve also and for median nerve also, which are supplying the intrinsic muscles of hand. So basically, I can say hand muscles are supplied by the C8 and T1. Mainly by ulnar nerve, but some of them are median nerve only. But the intrinsic muscle of hand innervation come from C8 and T1. And if the intrinsic muscle of hand are gone, what will happen, guys? The one common function of intrinsic muscle of hand is what? They cause flexion at metacarpophalangeal joint and extension at interphalangeal joint. Flexion at MCP and extension at IP joint. If this function is not working, then there will be extension at the metacarpophalangeal joint and flexion at the interphalangeal joint, and everyone knows that is what? The claw hand. So there will be hyperextension at metacarpophalangeal and there is a flexion at the interphalangeal joint, and that is nothing but the claw hand. Look at the MCP joint, guys. Sorry. Look at the metacarpophalangeal joint over there. That is showing the hyperextension. It's not only extended, it's hyperextended. And look at the interphalangeal joint in this case, they are flexed. The flexion. That is the claw hand here. That is the claw hand. Horner syndrome can also be there in the Klumpke's palsy because the injury is to C8 and T1, and T1 is a sympathetic nerve. T1 is the first sympathetic nerve. So Horner syndrome ho bhi sakta hai, nahi bhi. Horner syndrome is like something which is not always seen, but claw hand. If you have to choose between the claw hand and Horner syndrome, which was actually an INICT question, they gave both in the option, but you have to choose one out of the two. Claw hand is your best answer, no doubt about that. Horner syndrome may be seen if the sympathetic root value is also affected. Chali. Moving on to the three major nerves and their injuries to wrap up this upper limb part, guys. Radial nerve, ulnar nerve, and median nerve. So first, the radial nerve. Look, I want all of you to look at the screen here and just look at this little animation there. See, radial nerve, guys, it starts from the axilla. It goes behind the spiral groove, comes in front of the lateral epicondyle, and then it divides into two branches. One is called as a posterior interosseous nerve because running behind the interosseous membrane. And then there is a superficial branch of radial nerve, which is a cutaneous nerve. That is a radial nerve. It is running behind the spiral groove and then coming in front of the lateral epicondyle, dividing into two branches. Posterior interosseous nerve, which is purely a motor nerve, and superficial branch, which is purely the sensory branch. Radial nerve supplies the triceps in the axilla. Radial nerve supplies triceps in the spiral groove. Radial nerve supplies one wrist extensor called as ECRL, extensor carpi radialis longus, above lateral epicondyle. Dekho, most of the wrist extensors are supplied by posterior interosseous nerve, but there is one major wrist extensor, that is ECRL, is supplied by the main radial nerve only, and that too above the elbow only. So remember that is one of the wrist extensor. Then the posterior interosseous nerve will supply remaining all extensors. Whatever extensors are there, again names are not important, function is important, guys. Extensors of the fingers, extensor digitorum, extensor digiti minimi, extensor pollicis longus, pollicis brevis, jo bhi hai, all extensors are supplied by the posterior interosseous nerve. And superficial branch, obviously the name says superficial branch, it is a cutaneous nerve supplying the skin on the lateral 3.5 of the dorsum of the hand. Lateral 3.5 of the dorsum of the hand. Radial nerve injury could take place in the axilla, that is a crutch palsy. in the spiral groove, that is a Saturday night palsy. In front of the lateral epicondyle, could be because of the lateral epicondylar fracture, though it's not the most commonly involved of the lateral epicondylar fracture, but yeah, it can be involved in the lateral epicondylar fracture also. And the posterior introitious nerve, which can be involved sometime because of the radial head fracture also. But again, there could be various reasons for that. So the four common site for radial nerve injury, guys. If the radial nerve is injured as high as this point, this point here, that is in the axilla, the crutch palsy, then everything supplied by radial nerve is gone. That means all the extensors are gone. That means every joint will come into flex position. Tricep is gone, elbow is flexed, wrist is flexed, fingers are flexed, and sensory loss is there. Look at me, guys. So flexed elbow, wrist drop, finger drop, and sensory loss is also there because superficial branch is involved. That is in case of the crutch palsy. Flexed elbow, basically every joint is flexed because all extensors are supplied by radial nerve only. So सारे joint flex हो जाएंगे यहाँ पे. Flexed elbow, wrist drop, finger drop, and then we have sensory loss. But if radial nerve is injured at point B, then some part of tricep will be spared. Tricep is not completely involved now. Some part of tricep will be spared, and because of that, what will happen? Now, there is a weakness in elbow extension. There will be weakness in elbow extension, and rest everything is still the same. We still have wrist drop, we still have finger drop, we still have sensory loss, but there is this weakness in the extension of elbow. If the nerve is injured in front of lateral epicondyle, then tricep is perfectly all right. So tricep is perfectly all right. So Zindabad, elbow is fine. ECRL is also spared, and guys, ECRL is one of the wrist extensor. If one of your wrist extensor is spared, you will not have a wrist drop. Weakness hoga, definitely weakness will be there, but wrist drop is not there because ECRL is still working. But rest everything will be seen. That means finger drop will be there and sensory loss will be there. So no wrist drop this time, but finger drop and sensory loss is seen. Finger drop and sensory loss. And if posterior introitious nerve is involved, then in this case, sensory loss bhi nahi hoga because sensory branch will be spared. If the injury is to this posterior introitious nerve, then only finger drop will be seen and nothing. No sensory loss on the dorsum of hand because superficial branch is spared. That's the radial nerve injury and the level of the radial nerve injury and what will happen here. And again, it's, because as a traditional question, guys, they can ask you a question by just formulating anything new. They'll ask you, okay, the nerve is injured at this point, nerve is injured at that point here. So knowing that what major muscles are supplied by radial nerve and what is their function, more than the name of the muscle, the function is important. For you people, it's not extensor carpi radialis longus, extensor carpi radialis brevis. उससे ज़्यादा important ये है कि you should know that the muscle says extensor carpi. It's a extensor of the wrist. The action is more important. The patient will not come to you saying that my tricep ka long head is not working. वो तो simply कहेगा, obviously my tricep is not, like I'm not able to extend my elbow. No patient is going to complain of an individual muscle that I'm not able to use my flexor carpi ulnaris, so that's I'm not able to do the ulnar deviation. So you have to look at the clinical question based on that ability and inability of the movement here. So remember the muscle and their action in a group rather than remembering the individual name of the muscle. That will not serve you much. Chali sir, moving on to the next one, that is median nerve. Guys, median nerve root value is C5 to T1. Again, just like radial nerve, the root value is C5 to T1. So median nerve, it starts in the axilla by lateral root and medial root, but median nerve doesn't supply anything in the axilla and anything in the arm. Nothing is supplied by median nerve in axilla and arm. So median nerve, guys, if this is a median nerve coming down, as you can see, it is one of the most medial content of cubital fossa. And after crossing the cubital fossa, you can see it runs in the forearm and then it passes deep to the flexor retinaculum. That's a flexor retinaculum, the green one over there, and the nerve is passing deep to it. That's why it is involved in carpal tunnel syndrome also. Let me start from the distal end, guys. The median nerve in the hand, when we discuss the thenar and hypothenar muscle, median nerve was supplying the thenar muscles except adductor pollicis. It was supplying the thenar muscle except adductor pollicis, and this was also supplying the lateral two lumbricals, the first and second lumbric. That's exactly the thing. Thenars and lateral two lumbricals except adductor pollicis, which is supplied by ulnar nerve. Then this median nerve, before the median nerve passes deep to the flexor retinaculum, there is a nerve which passes superficial to the flexor retinaculum, and that is called as the palmar cutaneous branch of the median nerve, guys. Palmar cutaneous branch. In fact, the speciality of this nerve is this is the only branch of the median nerve passing superficial to the retinaculum. That's why when there is a carpal tunnel syndrome and the nerve is compressed at this point here, then obviously everything supplied by the median nerve in the hand will be gone. But the palmar cutaneous branch will be spared. And that's why in the carpal tunnel syndrome, patient may not have a sensory loss on the palm. Finger pe to hoga, but on the palm you may not have a sensory loss because palmar cutaneous branch is not passing deep to the retinaculum, it is superficial. Let's go further above. Median nerve is the main nerve of the forearm, And one nerve, it is not possible for one nerve to supply everything, guys. Median nerve is supplying the superficial plexus, and there is a branch of the median nerve called as anterior interosseous nerve, which is supplying the deep muscles. Posterior interosseous nerve was the branch of the radial nerve. It was a continuation of radial nerve. Anterior interosseous nerve is the branch of median nerve, which is supplying some of the deep muscles. So the main median nerve job is to supply what? Superficial plexus, like flexor digitorum superficialis, flexor carpi radialis, pronator teres. Don't have to write every name. Flexor digitorum superficialis is good enough. Anterior interosseous nerve will supply the deep muscle, and the two deep muscle, the two very, very important deep muscle, guys. One is flexor digitorum profundus, lateral half, flexor digitorum profundus, lateral half, and also flexor pollicis longus, FPL, flexor pollicis longus here. And I'll tell you what is the specialty, guys. Flexor digitorum profundus is for the distal interphalangeal joint flexion. That's the only muscle reaching the distal interphalangeal joint. If you want to do the distal interphalangeal joint flexion, that is done by FDP, flexor digitorum profundus. And same for the thumb also. Interphalangeal joint of the thumb is flexed by the flexor pollicis longus. Flexor pollicis longus. That's the important. Anterior interosseous nerve now काम नहीं करेगा, तो you will not be able to flex this distal interphalangeal joint, and you cannot flex the distal interphalangeal joint of thumb also. That's more important, right? Well, one shot is a program, guys, where I have to tell that what not to study, of course. I mean, if I keep telling you this to study, that to study, or wo to obviously anyone can do that here. But I need to tell you certain topic which, and I do feel responsible about it when I say, okay, you can leave that part. I'm not the creator of paper or anything like that. Obviously, there could be something which I say, don't read that, and they might create a question from there. My motive here is to tell you that what is the proportion of time you need to invest for which the returns are good. If let's say you're spending 5 hours on one topic and you're spending 1 hour on another topic here, and if I say that chances of getting a question more from that 1 hour topic here, then I would say chuck that 5 hour wala, leave that part here. Why to do that? In fact, my main motive of this one shot today is I thought I'll give it a name also, give it a theme or some name only, and the question is, why would I do that? Like, the things are not required, why would I do that here? And you probably will find some of the meme in between that which says that why would I do that? Okay. Yes, but a pronator quadratus also. But I did not write the pronator quadratus because that is not required. Again, my point is to tell you the just major muscles only. Look, median nerve can get injured here at the cubital fossa level. That is higher injury. Median nerve can get injured at the carpal tunnel syndrome. And there could be the direct trauma to anterior interosseous nerve. Remember, supracondylar fracture, anterior interosseous nerve can get involved. So let's talk about the 3 level of median nerve injury. If median nerve is injured here, that means everything supplied by median nerve is gone. Especially thenar muscles are gone. Doesn't matter injury is here or the injury is here. Thenar muscle dono mein jayega. So there will be ape thumb deformity. Now, along with ape thumb deformity, what will happen? Because FDS, now guys, please look at the screen here. Because the injury is here, so FDS is not working, and FDP lateral half is also not working. So I cannot flex these 2 fingers at all. Neither FDS nor FDP of the lateral side is working. So no chance I can flex these 2 fingers. In some people, they can flex middle finger, but index finger to definitely nahi hoga. So when you ask these patients to make a fist, they will make a fist like this. That is called as a pointing index finger. Or they will make a fist like this just by flexing these 2 fingers, and that is called as hand of benediction. That depends from person to person. Some people will have a pointing index finger, and some people will have a hand of benediction while making fist. Ye nahi bhulna beta. While making fist, the patient will not come to you with a pointing index finger likhe aa raha hai aise aapke wahn mein. He's just having ape thumb deformity only. The moment you ask the patient to make a fist, then only you will see a pointing index finger or hand of benediction, and that's the indication of higher injury here. So there is ape thumb deformity and there is a hand of benediction, like see it's a hand of benediction over there. If only index finger is like, you call it like pointing index finger. That is the higher injury. If the injury is lower at the carpal tunnel, then obviously there is no hand of benediction because FDS is working, FDP is working. So when you ask the patient to flex the finger, wo kar lega. He will be able to make a fist. So ape thumb deformity will be there, but there is no hand of benediction. But what will you see? The palmar cutaneous branch is spared, and because of that, there is no sensory loss on the palm. The sensory loss on the palm will not be there. So ape thumb deformity is there, but there is no sensory loss on the palm. Sensory loss will be seen on the fingers, but palm pe nahi hoga, and that is just an indication of it's a carpal tunnel syndrome. Obviously you do so many tests and everything for carpal tunnel syndrome, Tinel sign and Fallon's test and all that. It's just about observation I'm talking about. And then coming to anterior interosseous nerve, if anterior interosseous nerve is injured, then what is the case, guys? In the injury to the anterior interosseous nerve, what will happen? The patient will not be able to flex the distal interphalangeal joint of index finger. If I just take the index finger as an example, and the index interphalangeal joint of thumb, so you cannot make a circular OK like this. Or these patients have a difficulty in picking up the object. Like if you just leave a button on the table and you ask them to pick up a button, a button pick करने के लिए obviously you have to flex these joints like this, and the patient is not able to flex this. That's the positive OK sign. You ask them to make a OK like this, the weak OK sign here. Look at this. That's a positive OK sign. If you look at that hand on the other side here, that is circular OK. Perfect. But if my anterior interosseous nerve is injured, I will not be able to make a OK sign. So my OK will be more like a flattened or oval OK like this here. That is a weak OK sign. It's an indication of anterior interosseous nerve injury. First year वापस नहीं जाना है, first year को यहाँ पर लेके आना है, and we have to nail down that first year in these couple of hours only. Chalo guys, coming to the last thing, that is ulnar nerve. I mean last thing in the upper limb, that is ulnar nerve. Ulnar nerve root value is C7, C8 and T1. C7, C8 and T1. Guys, ulnar nerve is the one which passes behind medial epicondyle. It runs on the medial side and then it passes superficial to the flexor retinaculum. Look at the ulnar nerve. It is passing behind the medial epicondyle and then it passes like superficial to the flexor retinaculum only. Now it passes through a canal here and it passes through a canal here also. The flexor carpi ulnaris is the muscle between the two heads of flexor carpi ulnaris. It is passing and that is called as a cubital tunnel. Between the heads of the flexor carpi ulnaris muscle, that tunnel is called as a cubital tunnel. So compression of the ulnar nerve in this tunnel is called as a cubital tunnel syndrome, and compression of the ulnar nerve here in this Guyon's canal is called as a Guyon's canal syndrome. Higher injury, lower injury. Ulnar nerve obviously supplies flexor carpi ulnaris. That is a muscle it is passing through. Guys, एक गलती नहीं करना. Cubital fossa syndrome. Cubital fossa syndrome is a median nerve injury because it is a content of cubital fossa. Cubital tunnel syndrome is the ulnar nerve palsy. So ulnar nerve is cubital tunnel, median nerve is cubital fossa. So it passes through flexor carpi ulnaris, and in the forearm, apart from flexor carpi ulnaris, there is only half muscle left there to be supplied by this nerve, and that is flexor digitorum profundus, medial half. It supplies the medial half of flexor digitorum profundus there. Okay. So, we're going in the reverse manner here. So, there's a branch of the ulnar nerve which goes inside after crossing the Guyon's canal. That is called as a deep branch. That's a main branch here. And there is a superficial branch also. A small superficial branch is there. So, as I said, flexor digitorum profundus, medial half of flexor digitorum profundus is supplied by the ulnar nerve in the forearm. So, only 1.5. Flexor carpi ulnaris is 1.5 of FDP. Only 1.5 muscle are supplied by the ulnar nerve in forearm. और हैंड में तो इसने ऑब्वियसली तबाही मचाई. हैंड में तो ऑलमोस्ट एवरी मसल इज सप्लाइड बाय अल्नर नर्व ओनली. ऑल हाइपोथेनार्स, ऑल इंटरोशियाई, 2 lumbricals also, even one palmar one adductor pollicis also. So ulnar nerve deep branch, guys, this deep branch over there, it is supplying most of the muscle. It supplies hypothenars, it supplies interossei, it supplies 3rd and 4th lumbrical, and it even supplies one thenar muscle also, and that is the last muscle, that is the adductor pollicis. That is adductor pollicis. I told you it is also called as a graveyard of the ulnar nerve. Now, ulnar nerve injury can be higher, ulnar nerve injury can be lower. It can be a, as I said, cubital tunnel syndrome, it can be a Guyon's canal syndrome. Whether it's a higher injury or lower injury of the ulnar nerve, guys, the point is ulnar claw hand to hoga. Because intrinsic muscle of hand are involved, so obviously claw hand will be there, ulnar claw hand will be there. The only thing is that if the injury is lower, like in Guyon's canal syndrome, you have a we have more prominent claw hand in this case. But if the injury is higher, you have a less prominent claw hand, and that is called as a ulnar paradox. And the one which is responsible for this ulnar paradox is the flexor digitorum profundus muscle. This muscle is the one which is responsible for that. Because if the injury is lower, here, then what will happen? FDP will be working. You already have a claw hand because the injury is lower, and your FDP is working. Working FDP means it will flex the distal interphalangeal joint even more. That causes more flexion, and that's a very severe claw hand. But if the injury is higher, then FDP is also gone. So claw hand is there, but distal interphalangeal joint cannot be flexed, so it looks like a less severe claw hand in that case. So that is called as an ulnar paradox, and the muscle responsible for that is a flexor digitorum profundus. Everyone knows the ulnar paradox here, but if you ask which muscle is responsible for the ulnar paradox, it's the flexor digitorum profundus. It's a flexor digitorum profundus. So guys, this is about the upper limb part. The histology shots is coming. Give me 30 seconds. I need to use this throat after today also. So I'll give you a break after the lower limb only. I hope that you don't mind that. Chalo guys. The break is over. Lymph node, spleen, palate and tonsil, thymus. Histologically, some important differences, guys. Lymph node is something which you can divide into cortex and medulla. I'll show you the slide after that. I'm just tell you a basic difference first. Lymph node can be divided into cortex and medulla. Thymus can also be divided into cortex and medulla, but medulla is like common medulla is there. We have like a common cortex is there, and then we have the medulla in between. Spleen के अंदर there is no cortex medulla, no differentiation. When you look at the section of the spleen, there is no cortex, there is no medulla, सब कुछ mix है आपस में. That there is no cortex and differentiated cortex medulla is there. And palatine tonsil, it is differentiated basically by on the basis of stratified squamous epithelium. One of the main feature will be the lining surface पे. Again, no cortex medulla there. It's a stratified squamous epithelium that you will see on the surface. Lymphatic nodules are present where? Lymphatic nodules are present in the lymph node. We have lymphatic nodules there in the cortex part. Spleen में we have lymphatic nodule, and the speciality of the lymphatic nodule in spleen that they have an artery inside. Splenic artery उसके अंदर मिलेगा आपको. You have a splenic arteriole inside. Palatine tonsil में lymphatic nodules are present, and again I said by looking at the stratified squamous epithelium you can identify them. और thymus में तो lymphatic nodule होता ही नहीं है. There is no lymphatic nodule as such in this. Subcapsular sinus, there is something called as a subcapsular sinus which is present. I'll show you where the subcapsular and subtrabecular sinus are. I'll show you in the picture, guys. That is there in the lymph node. Spleen ka one of the main features of spleen is a red pulp and white pulp. We have a red pulp and the white pulp, which is an indication of closed circulation and open circulation in the spleen. And palatine tonsil mein tonsillar crypt. You may be able to appreciate the tonsillar crypt in that. You will see the stratified squamous epithelium dipping inside, forming the tonsillar crypt in that case. And thymus ke andar we have, in the medulla part, we have Hassel's corpuscles or thymic corpuscles. Okay, let me show you the slide for the lymph node, spleen and palatine tonsil because they all have lymphatic nodules, so you should be able to differentiate them with each other easily. Guys, this is a picture of a lymph node right now. Now, why I'm saying it's a picture of a lymph node, first of all, you can divide it into the cortex and medulla. See, outer part there is a cortex here and the inner part is medulla. And look at the lymphatic nodule are present only in the outer part. Bahar wale part present, that is a cortex. They are present, isolated lymphatic nodules are present only in the cortex. You can see capsule there. And the space that you see deep to the capsule and trabeculae, this is called a subcapsular and subtrabecular sinus. Look at that space here. And that's a very unique feature of the lymph node. They have a sinus or space deep to them called a subcapsular or subtrabecular sinus. Subcapsular or subtrabecular sinus. Then we have, what do you say, just like capsule, we have a trabeculae also, guys. That is a trabeculae is also present. Okay. And lymphatic nodule, which is mainly having the B lymphocytes, the lymphatic nodules have B lymphocyte. But a T lymphocyte, you're asking, T lymphocytes are present mainly in this area, that is paracortex here. The junction between the cortex and medulla, there is a paracortex region. This is some thymus dependent zone we bolte. That's why it is called as thymus dependent zone, because it's a paracortex here. And this is where the T lymphocytes are present. This is also called a thymus dependent zone of the lymph node. So that is a lymph node, guys. Capsule is visible, subcapsular sinus dikh rahe hain. You can see lymphatic nodules without artery present only in the cortex part. That is the lymph node. When you look at this picture here, you can, first of all, you can clearly make out it is a palatine tonsil. Well, guys, lymphatic nodule is there. You can see those lymphatic nodule is there. But the main thing is one that's the tonsillar crypt, the big crypt can be seen over there. And major point is the stratified squamous epithelium. That's no capsule there. That's a stratified squamous epithelium. In fact, I believe that when they give the question, when they give the picture of this, the palatine tonsil, they will show you a more magnified picture. So you may not be able to see the tonsillar crypt, but you should be able to see the stratified squamous epithelium here. Because otherwise there are other slides you can confuse it with here. So I feel that if the palatine tonsil is asked as an image-based question, they need to magnify more toward the stratified squamous epithelium just to confirm you're looking at lymphatic nodule, you're looking at stratified epithelium. ठीक है यार, this is what? This lymph node. This is palatine tonsil, I'm sorry. And spleen. Look at this. First of all, it's a low magnification picture. You can see lymphatic nodules, and these lymphatic nodules are present everywhere, guys. There is no differentiated cortex and medulla. I cannot differentiate cortex and medulla. You can see the lymphatic nodules are present everywhere. That is what is there in the spleen here. And if I just magnify a picture toward one lymphatic nodule, you also see the blood vessels inside. The blood vessels are seen inside. As you can see, this is a lymphatic nodule there. There's a lymphatic nodule. Look at those arteries, guys. You can clearly see one artery inside that. You can see one artery over there. You can see the artery here also. These are all splenic arteriole. And that's a unique feature of the spleen, that the arterioles are passing through the lymphatic nodule. There is no arteriole in the palatine tonsil, there is no arteriole in the lymph node, but in spleen there are arterioles which are present in the lymphatic nodule, which is a feature of that. Lymphatic nodule is having WBC, so this is called as the having all those lymphocytes and white blood cells are there. So this is a white pulp. And when these arteries they come out, they splay their blood into parenchyma. So you can see all this red tinge over there. It is because the RBC is present over there, and that is called as a red pulp, guys. That's the red pulp and the. So that's a slide of a spleen here. That's a white pulp over there. Lymphatic nodule is a white pulp only, and that red tinge in between here, where the RBCs can be seen, that is the red pulp. And as I said, the main thing is in the lymphatic nodule, you will see what? Eccentrically placed splenic arterioles. Splenic arterioles are present in them. Chali sir, so that was about the how to differentiate between the lymph node with the palatine tonsil and the spleen. If I just very quickly recap that part here, if you're looking at the lymphatic nodules present in the cortex, only in the cortex, and you can see subcapsular or subtrabecular sinus, lymph node. If you're looking at the lymphatic nodule, and along with that you can see stratified squamous epithelium, palatine tonsil. If you can see lymphatic nodule present everywhere, no differentiation, and you can see artery inside, spleen. Plus, if you just remember this much also, you still will be able to identify these slides here. And what I've seen from guys from last 4 or 5 years, they do not ask you any detail about the slide, they just ask you to identify. Like they are also fed up with us, like the kind of histology we read in first year. Now examiner just says, okay, bas, identify kar do ki kaun si slide diya, but that's all we want from you here. So no detail or nothing is asked. Okay, sir, that takes us to our next unit, and that is lower limb. So, jaldi se lower limb ko khatam karte, then we'll take a break after that. Okay, so guys, to start with the lower limb, I'm gonna start with the plexus, that is a lumbar plexus. Let's look at the muscle that is a psoas major and iliacus muscle, and based on that, let's identify the lumbar nerve, because there's some really good clinical question, and it's more like a surgical based question asked on those nerves here. Yeah. Thank you, guys. You stay motivated, and you just better keep me motivated also. I also need a lot of energy to go with this. Okay. Because when you're writing, you're kind of taking a rest in between while writing. But when if it is everything is written over there, I have to speak continuously. Guys, psoas major and iliacus. Now look at the muscle, the psoas major muscle. You can see it's coming from the lumbar vertebrae. The psoas minor is also visible there, but that's a psoas major muscle, and that's a psoas minor muscle present on it. And this muscle is coming from the iliac fossa, that is iliacus. Just focus on these two muscles. Baki sabko bhul jao. So it's psoas major muscle and iliacus, and both psoas major and iliacus, if you look at them, they are converging together to form a common tendon called as the iliopsoas tendon, which is inserted to the lesser trochanter. Inserted to the lesser trochanter. That's a lesser trochanter. Okay, chalo, keep these two muscles in mind, and let's identify the branches of lumbar plexus. Psoas major muscle is the one which is hiding the lumbar plexus. The entire lumbar plexus is hidden by the psoas major muscle, and I maybe some of the people from that batch is in this what do you say, might be attending this class right now. Just few days back I was taking a class in Hyderabad, and I came to know that I think 2018 or 2019 batch, they had psoas major muscle as a long question in their exam. And I was like taken back, like, what, yaar, long question? I mean, who was that distorted examiner who asked a long question? Psoas major pe kaun long question puchta yaar? But hai, that was asked. And since that time, this year, all the batches in Hyderabad and Vizag and Vijayawada, I'm naming those batches as psoas major batches only. So I call them psoas major 1, psoas major 2, psoas major 3. So I'm done with psoas major 3 batch till now. After 4 or 5 days, I'm going again for the next batch there. So psoas major, guys. So that reminds me more of this muscle. This muscle is hiding the psoas major muscle is hiding the lumbar plexus. The lumbar plexus all behind that, L1, L2, L3, L4 nerve, वो सब इसके पीछे present है. So for the lumbar plexus nerves to come out, now they have 3 options. Either they will come out from the posterior side of psoas major, or they will pierce the psoas major, or they will come out from medial side of psoas major. Yeah, 18 batch. Yes, that was the 18 batch. Yeah, I hope that some of you are there. Okay. Okay. Now look at, guys. Please look at this picture, because when you look at the final picture, this will be like there's too many things on that. So I want all of you to please focus and look at this picture very carefully, guys. What you're looking at right now, it's a lumbar plexus present on the psoas major muscle and psoas minor. Now look at the nerves, guy, over there. You have multiple nerves. If I start from the topmost nerve, I want for all of you to look at these nerves based on the psoas major muscle. Look at the nerves which are coming out from posterior side or lateral to psoas major. हम फिर देखेंगे nerve piercing it, then we'll see the nerve medial to it here. Just look at the nerves which are lateral to it. This nerve is coming out just below the medial lateral arcuate ligament. Its arcuate ligament is a part of diaphragm only. So it is basically coming out between the 12th rib, and that nerve is a subcostal nerve, the T12. That is a subcostal nerve, the T12 nerve. Just below that, we have a nerve, two nerves which is coming from L1. One is iliohypogastric and then ilioinguinal nerve. Iliohypogastric ऊपर वाला है, उसके नीचे वाला ilioinguinal. Iliohypogastric, ilioinguinal nerve. Ilioinguinal nerve is a content of inguinal canal also. Iliohypogastric, ilioinguinal nerve. And then look at the another nerve which is coming out from the inner aspect of this iliacus muscle, from the iliac fossa. That is the lateral cutaneous nerve of the thigh. That is lateral cutaneous. I'll tell you more about this nerve here. That is lateral cutaneous nerve of thigh. So guys, focus on the psoas major muscle and look at the three nerves, the four nerves in fact, which are actually present coming out lateral to psoas major. या पीछे से आ रही है, ऊपर से आ रहे हैं, but they're outside or lateral to psoas major. So subcostal nerve, iliohypogastric, ilioinguinal nerve, lateral cutaneous nerve of thigh, and you'll identify the lateral cutaneous nerve of thigh by looking at the iliac fossa. The nerve is running within the iliac fossa only like this. Then you look at the nerve which is piercing the psoas major muscle and coming out, and that is the genitofemoral nerve, the nerve which pierces and comes out. So sorry, femoral nerve is also there. I forgot to tell you here that look at that nerve which is coming out between psoas major and iliacus. That small nerve over there, not small nerve, actually nerve is big, but you can just see a very small part of that. The nerve present between the iliacus and psoas major, that is a femoral nerve. So all these nerves are present lateral to psoas major. One nerve which is piercing the psoas major and coming out, that is what, guys? Genitofemoral nerve. That is genitofemoral nerve. It is piercing and coming out. And one nerve is medial to the psoas major. Look at my finger over there. That nerve over there is the obturator nerve. The nerve supplying the medial compartment of the thigh, obturator nerve is present medial to it here. So identification of the lumbar plexus is based on the psoas major muscle here. Psoas major batch, if you're there, you to at least should be able to identify them all the time. Okay. Subcostal nerve, guys, please stay on this. Subcostal nerve, iliohypogastric nerve, and ilioinguinal nerve. Look at these three nerves here. What makes them so important? Because they are present just behind the kidney. They are forming the posterior relation of the kidney. On the other side, look at that animation, guys. There's a kidney over there. I just pasted the kidney over there. So kidney के पीछे तीन nerve present है. Subcostal, iliohypogastric, and ilioinguinal nerve. So that's why in the renal surgeries, when you approach the kidney from the posterior side, then obviously the three nerves which are vulnerable to injury is subcostal, iliohypogastric, and ilioinguinal nerve. Similarly, genitofemoral nerve, lateral cutaneous nerve of thigh, and femoral nerve. Look at these nerves, guys. Let me point out here. Look at this area here. Actually, I should have pointed out on the other side, but my hand will cut. I'll go out of the frame. Look at these three nerves in this region. On the right side, obviously, the cecum is present there. So these three nerves are forming the cecal bed. The surgeries of the cecum or retrocecal appendix, the nerve which is vulnerable to injury are these three. Look at the cecum over there, guys. I put that. And the nerve vulnerable to injury are what? Genitofemoral nerve, lateral cutaneous nerve of thigh, and the femoral nerve. An obturator nerve, when it runs from the inner aspect from the pelvic cavity, it is in very close relation to the ovary. So it's in close relation to the ovary here. So you should know that, okay, what nerve can get injured in these surgeries here? Any renal surgery, the subcostal, iliohypogastric, ilioinguinal nerve. Cecal surgeries, the three nerves over there. Again, the nerve in close relation to ovary, that is ovarian carcinoma, can involve the obturator nerve. And if obturator nerve is involved, there will be the issue with the adduction, because obturator nerve supplies all the adductors and also supplies the skin on the inner aspect of the thigh. Last year, I think 22 or 21, there was the question on the psoas abscess also. If you've seen the psoas major muscle, you will not miss the psoas abscess, guys. Psoas abscess, that's a picture of the psoas abscess. You can see the lumbar vertebrae. You can see psoas major muscle. That's a psoas abscess here. It is trickling downward. That's the iliacus muscle here that I'm pointing at. That's the iliacus muscle. That is psoas major muscle. And this psoas major muscle will trickle down and goes downward, and it will reach the lesser trochanter. And lesser trochanter is the point. I mean, if imagine if the abscess will go toward the lesser trochanter, it will accumulate there. It may give a false appearance of the inguinal hernia also. So when you do the differential diagnosis of the inguinal hernia, the psoas abscess also is to be counted in that. Couple of muscles to be involved in that, guys. Couple of muscles to be involved in this. Like couple of important nerves which need to we discuss here. Like what is that nerve, guys? The nerve which is piercing the psoas major muscle, that is genitofemoral nerve. That important nerve is genitofemoral nerve. Ab the next two nerve which I'm going to discuss, guys, they are very, very commonly asked question in the exam, so don't miss out on them. Genitofemoral nerve, which is piercing the psoas major muscle and coming out, it is dividing into two branches. The lateral branch is called as the femoral branch, And the speciality of the femoral branch is that it is supplying the skin over the femoral triangle. You can see the nerve coming out there and it is supplying the skin over the femoral triangle. Look at the triangle over there, guys. So skin over the femoral triangle is supplied by the femoral branch of genitofemoral nerve. Whereas the branch which is present on the medial side, that's a genital branch of genitofemoral nerve, and the genital branch of genitofemoral nerve, it supplies the cremastric muscle. It supplies the cremastric muscle. And that gives rise to some very important questions. When you test the cremastric reflex, you scratch along the medial aspect of thigh. So you are stimulating the femoral branch of genitofemoral nerve, and the efferent of the cremastric reflex will go from the genital branch of genitofemoral nerve. आप इसको स्टिमुलेट करेंगे, रिस्पॉन्स ऑब्वियसली इस मसल के ऊपर आएगा. सो आई कैन से genitofemoral nerve is the main nerve for the cremastric reflex. Afferent will go from the femoral branch, and efferent will come from the genital branch of genitofemoral nerve. Secondly, because femoral branch of genitofemoral nerve is supplying the skin exactly over the femoral triangle, and this was a last year question again, guys. If you're doing the femoral vein cannulation, abhi femoral vein cannulation mein we have to anesthetize the femoral triangle skin only, and that is supplied by what nerve only? The femoral branch of genitofemoral nerve. So the two very, very important point, that the afferent and efferent limbs of cremastric reflex, that is by the genitofemoral nerve, and the femoral branch of genitofemoral nerve, it is anesthetized in femoral vein cannulation. In femoral vein cannulation. Okay. The next important nerve which I want to show you here, I hope you are identifying this nerve, guys. Look at the nerve which is running within the iliacus muscle and then coming out. That is the lateral cutaneous nerve of thigh. Actually, there are three cutaneous nerves which are supplying the thigh, anterior compartment of thigh. I mean, thigh is supplied like we have a nerve which is present on this side, that is called as the lateral cutaneous nerve. Then we have intermediate, and then we got a medial cutaneous nerve. So intermediate and medial cutaneous nerve of thigh are the branches of femoral nerve. Only lateral cutaneous nerve of thigh is directly coming from the lumbar plexus. And that's the thing, because this nerve is coming directly from lumbar plexus, so you see the nerve is very, very, like when it leaves the, the iliac fossa and enters the thigh, it sometimes pierces the inguinal ligament or passes deep to inguinal ligament, and this is the point where the nerve can get injured also. Extreme flexion, guys. If you go in the lithotic position, there is a flexion of the knee joint, this hip joint here. If you do heavy squatting, if you take a very heavy weights on the shoulder and you go for the squatting, then again the lateral cutaneous of thigh can get compressed or injured in that case, and in that case that will lead to the meralgia paresthetica. That will lead to meralgia paresthetica. The compression to the deep to the inguinal ligament, it caused this burning sensation and tingling sensation lateral side of thigh, and that is called as a meralgia paresthetica. That is a meralgia paresthetica toward the lateral aspect of thigh. I wanted to show the lateral aspect of thigh. The Bradley Cooper looks something else only. Like he doesn't look like having a meralgia paresthetica. It is like he's taunting someone. So I love Bradley Cooper, but this picture may not be appropriate for the meralgia paresthetica. Okay, let's move on. So guys, hip bone and femur, just couple of muscle attachment there. If you look at the 2 point, the 2 circle over there, one is at the ASIS, that is anterior superior iliac spine, and one is at the, okay, let me give you a few seconds to laugh about it, because I know otherwise you will not be in the frame of mind. He's seducing himself. No comments. Yes, 30 seconds break, correct. Don't worry, guys. I'll give you a break of 20 minutes in between when we're done with that, because that 5 minutes wala break mujhe nahi samajh mein aata hai. So 20 minutes break we'll have. So you just grab your cup of coffee or tea or something, and then only we'll start exactly in 20 minutes once we're done with this part here. So abhi don't move your ass from there. Okay. So guys, ASIS and AIIS, anterior superior iliac spine. That is the anterior superior iliac spine there, right? And it is giving attachment to two important sections. One is inguinal ligament, and one is sartorius origin, guys. Inguinal ligament and sartorius ka origin is from the ASIS, that is anterior superior iliac spine. And anterior inferior iliac spine, it is giving origin to the rectus femoris muscle. Quadricep muscle ke 4 parts, and the rectus femoris is the only portion which is coming from the hip bone, that is from anterior inferior iliac spine. Okay. Sartorius muscle and rectus femoris muscle, they're starting from the hip bone. From the front of the hip bone, one from AIS, one from IIS, and both will come in front of the hip joint. दोनों hip joint को सामने से cross करेंगे. And that's why both these muscles are responsible. They have a common function, guys. Both these muscles are responsible for the flexion of the hip joint. They will both be responsible for the flexion of the hip joint. Both rectus femoris and sartorius, they will be responsible for the flexion at the hip joint. I know you people are very tempting and interesting people to talk to, but अगर मैंने तुमसे बात करनी शुरू करी ग्रुप के अंदर, तो this session will go till morning only. So I want to finish it on time. So let me focus, guys. Flexion at hip joint, that is done by sartorius and rectus femoris muscle. Okay. If you look at the greater trochanter and lesser trochanter, I'll be able to show you the lesser trochanter better from the posterior side. Greater trochanter, one of the muscle that you can appreciate attached to the greater trochanter, that to the anterior side of the greater trochanter, that muscle will be the gluteus medius muscle. Minimus, I'm sorry. Medius is more toward the lateral side. It's a gluteus minimus more anteriorly placed here. And gluteus minimus muscle is even gluteus medius also, that will show from the posterior side, that is responsible for abduction and internal rotation, guys. Don't forget that. It is for the internal rotation and abduction at the hip joint. Abduction and internal rotation. I am trying very hard. If you turn this entire thing posteriorly, guys, look at this. If you turn this entire thing posteriorly, now I'm looking at the greater trochanter, lesser trochanter. And lesser trochanter is giving attachment to the iliopsoas, and greater trochanter, which is to be appreciated better from this side, although the muscle is attached on the lateral surface, and that is a gluteus medius muscle. That's a gluteus medius. Minimus was more anteriorly placed. And this obviously on the lesser trochanter is the iliopsoas muscle. Gluteus medius muscle, just like gluteus minimus, it is also responsible for abduction and internal rotation. It is for abduction and internal rotation at the hip joint. Whereas, and you know, any fracture of the greater trochanter, guys, obviously that will be a positive Trendelenburg test here. Look at this picture, the radiograph over there. You can see the fracture of the greater trochanter, and the fracture of the greater trochanter, obviously the two muscle will get affected in that. Gluteus medius or gluteus minimus, dono jayega. Gluteus maximus muscle is not attached to the greater trochanter. Don't forget that, guys. Gluteus maximus is attached to this area. Look at that here. That tuberosity is called as a gluteal tuberosity, and this is where the gluteus maximus muscle is inserted. One of the main attachment of gluteus maximus muscle is to the gluteal tuberosity. Onto the gluteal tuberosity, and gluteus maximus is the main muscle for extension and external rotation. External rotation. Please don't forget, gluteus minimus and medius hip को internal rotate कराते. They rotate the hip inwards. Okay. And external rotation of hip is done by the gluteus maximus. Other muscles also, but I'm talking about gluteal muscle. It's the gluteus maximus which is for the external rotation and the extension. Whereas the lesser trochanter, it gives insertion to the iliacus and psoas major. Both the muscles will come from the front like this, attached to the lesser trochanter, and they're very, very strong flexor of the hip joint. Look at this picture here, that's a lesser trochanter there. So muscle, iliopsoas muscle will come from the front here, and they will insert on this lesser trochanter, on the posterior side of lesser trochanter, and they are the strong flexors of the hip joint. Both iliopsoas are the strong flexors of the hip joint. That spine that you're looking at over there, guys, if my finger can reach there, yeah, somehow, that is called as the ischial spine. This is the one which is separating the greater sciatic notch and lesser sciatic notch. That spine is called as the ischial spine. And guys, this ischial spine is giving passage to, or there are three structures which are running on the ischial spine. That is the pin structures. P is pudendal nerve. There is internal pudendal artery or vessels, and the nerve to obturator internus. So there are three structures. They are actually going from the greater sciatic notch to lesser sciatic notch. These three pin structures are running on this ischial spine. So pudendal nerve, internal pudendal vessel, and nerve to obturator internus. And they ask this question that the fracture of the ischial spine or injury to the ischial spine, the main nerve which can get injured over there is a pudendal nerve. And guys, what makes pudendal nerve so important? That the nerve supplies the muscles of the perineum. The perineum, we'll be discussing the perineum at the end here. All the muscles in the perineum, guys, bulbospongiosus, ischiocavernosus, superficial transverse, deep transverse perineal muscle, external anal sphincter. ये जितनी perineum की muscles हैं, they are supplied by this pudendal nerve. So it is not wrong to say that if there is a fracture of the ischial spine, the pudendal nerve will get involved, and there will be paralysis of the muscles of the perineum, because pudendal nerve will get injured in that case. Another picture to tell you something. This is an image which is again shown from the posterior side. You can see the big gluteus maximus muscle here. But this image is mainly to show you this band here, which is called as a, guys, iliotibial band here. It's a tough fibrous band present on the lateral side. It starts from the iliac bone above and attaches to the lateral tibial condyle. That's the name is iliotibial band. It is a modification of deep fascia of thigh. Fascia lata ki modification hai iliotibial band. This iliotibial tract or iliotibial band, what makes it so important? The iliotibial band, first of all, it receives the insertion of two main muscle. It is modification of fascial lata. It receives the tensor fascial lata muscle, that is one TFL, tensor fascial lata. It's a gluteal muscle only, and even gluteus maximus. I already told you, gluteus maximus muscle, one of the attachment was to the gluteal tuberosity. You can see that. My finger again will be cut actually if I go there. Just look at that side, guys. You can see the gluteus maximus muscle attached there on the bone also, and it is attached to the IT band also. So gluteus maximus is attached to both. So iliotibial band is giving attachment to the gluteus maximus as well as to the tensor fascia lata. When there is a contracture of the iliotibial band, like in case of poliomyelitis, there is a contracture of the IT band. So when there is a contracture of iliotibial band, look at what is the position of the hip joint and knee joint, because the IT band is contractured. So what is the position of the hip joint? The hip joint position can be remembered as Faber, F-A-B-E-R, Faber, flexion, abduction, external rotation. Your hip joint will come into what? It will come into flexion, abduction, and external rotation. Flexion, abduction, external rotation. And knee joint will also come into flexion, and there could be external rotation of tibia also. So knee joint also comes into the flexion, and there is an external rotation of tibia as well. Right? Babinski, Proxy. There is hip joint, that is a Faber position, and knee joint, it is a flexion and external rotation. This is about the iliotibial band and IT band. Okay. Now, next picture that I'm going to show you guys, this is a picture. No, Ankur, there's nothing like that. You have to choose any one. You don't have to choose between the two attachments. This is not it's not a clinical question, okay, that I should give this to this patient or I should give that to the patient. Abhi dono jagah pe attachment hai, to both are attachment of this gluteus maximus. But if you still ask me, I would still say iliotibial band, because the major attachment, the most fibers of the gluteus maximus are attached to the IT band. But I don't think they will ask you a question like just choose between the iliotibial band and the gluteal tuberosity where maximus muscle is inserted. Aisa nahi hoga. That I can assure you. You're looking at the anterior compartment of thigh. Now, let's do one thing, guys. Let's look at the anterior compartment of thigh in the atlas image also and in one of the cadaveric picture also. The two pictures, let's compare them side by side here. The most landmark muscle here is the sartorius. The sartorius is the main muscle that you're looking here. Now, look at the sartorius muscle, and first of all, it will be good to discuss the sartorius action right now, because sartorius action is just like a TFL. What tensor fascial, iliotibial band contracture can do at the hip joint and knee joint is a normal function of sartorius muscle. वो तो contracture था. The normal function of sartorius is to cause the flexion, abduction, and external rotation at the hip, and flexion at the knee joint. And flexion at the knee joint here. Flexion, external rotation and abduction at the hip, and flexion at the knee joint. Again, last year, INICT, November INICT question, they asked that this is the action of which of the marked muscle, and sartorius को mark करना था उसके अंदर. So sartorius is a muscle for the flexion, external rotation and abduction at the Faber, and flexion at the knee joint. It's a normal action there. Okay, let me just tell you how to look at the anterior compartment of thigh. When you're looking at the thigh, anterior compartment of thigh, guys, look at the sartorius muscle first, which I'm sure everyone will be able to identify, and then just divide the thigh in two parts. Medial to the sartorius, everything that you see medial to sartorius here, it is all femoral triangle, and everything lateral to sartorius, it's quadriceps. So sartorius ko dhoond lo, sir. Lateral to sartorius is quadriceps, medial to sartorius, it's femoral triangle. So let me just go toward the lateral side first. Look at that muscle over there, that is a rectus femoris muscle. In this case, the rectus femoris part is cut over there so that they can show the vastus intermedius. Rectus femoris muscle is also a two joint muscle. If you remember, rectus femoris and sartorius both were originating from the iliac crest. One from the anterior superior iliac spine, one from anterior inferior iliac spine. So, and both rectus femoris and sartorius, they are crossing the knee joint. But look guys, what's the difference now? I want to demonstrate this to you. Sartorius muscle is crossing the hip joint, and even rectus femoris is crossing the hip joint from the front. So both these muscles at the hip joint are causing flexion. But rectus femoris, unlike sartorius, is not moving backward. Rectus femoris is running in front, and it is going in front here. It is attached to the tibial tuberosity by the ligamentum patelli. So it is a major extensor at the knee joint. Sartorius is causing the flexion at the hip and flexion at the knee joint because muscle पीछे turn करके चला गया. But rectus femoris stays in front only, so it is causing flexion at the hip, but the main function is the extension at the knee joint. We know the quadricep muscle is mainly for the extension here, so it is for the extension at the knee joint. It is the muscle is for the extension at the knee joint. That's the function of the rectus femoris muscle. Okay. Look, look at the muscle over there, the muscle that you see inside. You already know the iliacus muscle. That is the iliacus muscle in the cadaveric picture. You can compare it to the other side. That is the psoas major muscle that you can see again. And if I go further beyond that, that's a pectineus muscle. Look at it in both the picture, pectineus. And then the adductor longus. Though adductor longus is not the muscle of anterior compartment, but it formulates the floor of the femoral triangle. These four muscles in the sequence from lateral to medial side, iliacus, psoas major, pectineus, adductor longus, they are all forming the floor of the femoral triangle. They're all forming the floor of the femoral triangle. Okay. Gluteal region may, I mean, there's not much of a question in the gluteal region. The main question is here is a Trendelenburg test only, guys. Gluteus medius or gluteus minimus? Injury to the gluteus medius or gluteus minimus. Now, when I talk about the normal, that marked muscle, this is the gluteus maximus muscle there. And on the other side, the muscle which is marked over there is a gluteus medius muscle. Gluteus medius or even minimus if it is marked. The muscle action is like this. The normal action is abduction. If your gluteus medius is intact, let's say that if this is the right side, guys. It's a picture from the posterior side. So it's a right side. Right gluteus medius is intact. Then obviously when you lift this left foot off the ground, your pelvis is still leveled. But if gluteus medius is injured or superior gluteal nerve is injured, so gluteus medius muscle will not work or gluteus minimus will also not work because both are supplied by superior gluteal nerve. So in that case, if you lift this leg off the ground here, this pelvis will not stay like this. It will drop down something like this. Look at this. In this case, you can see the foot is lifted off the ground here. As Turanti, you can see pelvis is dropping from that side here. And that is because of the gluteus medius of the right side. It's a right side Trendelenburg test. Right side gluteus medius muscle. Right side superior gluteal nerve involvement. But pelvic drop on what side? Left side. Everything is of the ipsilateral side except for the pelvic drop, which is on the other side here. Even the gait of this patient will be, because his left pelvis is dropping. So every time he walk, he will just sway like this. He will go toward the right side so that he can lift the pelvis here. Look at this, guys. Look at this gentleman. When he's walking, he is swaying toward what side? Right side with sway kar raha hai. So he can lift the left pelvis up here. He's doing it because let me look. This side gluteus medius is not working. He wants to lift this pelvis and that's why he's swaying on that side. I will sway toward the right side to lift the left pelvis off the ground here. In simple language, in Trendelenburg test, right side gluteus muscle, right side gluteal nerve, right side, lurching will be there. It's a ipsilateral lurching is there, but pelvic drop is seen on the opposite, on the contralateral side. So if you see the pelvis is dropping on the left side, it is a right side. Everything is right side. The Trendelenburg sign is positive on the right side. Coming to the one important nerve in the lower limb, that is the sciatic nerve, guys. Sciatic nerve and the injuries. Look, when you talk about the sciatic nerve, first of all, sciatic nerve passes deep to the piriformis muscle. In some cases, it is piercing the piriformis muscle, and that is called as the piriformis syndrome when the nerve is compressed between them. One of the higher sciatica, that is a piriformis syndrome. So it is not supplying piriformis, it is passing deep to piriformis usually, not supplying anything in the gluteal region. Then sciatic nerve in the hamstring compartment supplies all hamstring, guys. All hamstrings are supplied by sciatic nerve. And now look at this. After that, the sciatic nerve divides into two branches. One is the tibial nerve. This is the tibial nerve here, the one which continues straight, and that is a common peroneal nerve. The common peroneal nerve is the one which will go and wind around the neck of fibula. That's a fibula over there. You can see tibia and fibula I put there, and that's a neck of fibula. The common peroneal nerve will wind around the neck of fibula, as you can see, and then divides into two branches. That's a very common point of injury for the common peroneal nerve also. Let me do that animation again. So that's the tibia and fibula, the neck of fibula. The common peroneal nerve winds around the neck of fibula from the popliteal fossa. It comes like this and then divides into two branches. The one which is toward the lateral side is a superficial peroneal nerve, and the one supplying the anterior compartment of leg, that is a deep peroneal nerve. SPN and DPN, superficial peroneal nerve and deep peroneal nerve. Superficial peroneal nerve and deep peroneal nerve. Now, what are they supplying? Again, names of muscles are not important. The function is important, guys. Tibial nerve is supplying the calf muscle, posterior compartment muscle. That means it is supplying the plantar flexus. It is supplying the plantar flexus. Plantar flexus, including tibialis posterior, which is an inverter also. That's the reason I wrote the name here. That plantar flexus is supplied by the tibial nerve, and it supplies the tibialis posterior also, which is an inverter. It is definitely a plantar flexor, but it is an inverter also. Then this nerve, it goes into the foot, divides into medial plantar nerve and lateral plantar nerve. Not very important, but lateral medial plantar nerve supplies the muscles in the sole of foot. Whatever muscles we have in the sole of foot are supplied by this medial plantar and lateral plantar nerve. Superficial peroneal nerve, it supplies the everters. peroneus longus and peroneus brevis. This pay attention to superficial peroneal nerve, guys, on that side here. That superficial peroneal nerve, it supplies peroneus longus and peroneus brevis, and both are everters. Whereas deep peroneal nerve, it supplies the muscle of the anterior compartment, and the muscle of the anterior compartment leg are what? They are dorsiflexors. They are all dorsiflexors. It supplies the dorsiflexors, including tibialis anterior, which is an inverter also. See, the problem is, guys, in the leg, we have three compartments. Look at anterior compartment of leg is for dorsiflexion. There's a limitation of the camera. I can't do this. I want to do so much for you. Like here, we have dorsiflexor, that is by the anterior compartment. Posterior compartment is doing the plantar flexion. Lateral compartment, the one which are outside, are doing everter. And we have compartment for these three. So there is no compartment for inverters. Abhi inversion kaise hoga? Any muscle of anterior compartment or posterior compartment, if they're entering the foot from medial side, they will cause inversion also, guys. Tibialis anterior, tibialis posterior. They're entering the foot. They're definitely dorsal and plantar flexors, but they're entering the foot from medial side. So they are inverters also. They help in the inversion. The inverter also. So you can see inverter written here also, and you can see inverter written here also, supplied by deep peroneal nerve. And then what is the fate? The superficial peroneal nerve and deep peroneal nerve. The superficial peroneal nerve supplies the skin on the dorsum of foot, major part of dorsum of foot, and deep peroneal nerve, very very important question पूछते हैं इसके ऊपर. Deep peroneal nerve supplies the skin of the first web space. It supplies the skin of the first web space. Okay. Tibial nerve injury and common peroneal nerve injury. What will be the case, guys? Let's start with the tibial nerve injury first. That एक tibial nerve injury का case. In case of tibial nerve injury, what you will see, what muscles are gone? Plantar flexors are gone. If plantar flexors are gone, then obviously, and major inverters are also gone. If your plantar flexors are gone, your foot will come into what position? Dorsiflex position. And because major inverters are also, foot will also come into what? Everted position here. So your dorsiflex foot and everted foot, that is a calcaneovalgus, guys. Look at the picture here. That's a calcaneovalgus foot here. Your foot is like dorsiflex like this, and it is everted also. Okay. And the type of gait these patients will have called as a calcaneal gait. They're walking on the heel only. That is called as a walking on heel. That is a calcaneal gait itself here. What will happen in case of the common peroneal nerve injury? That's the very, very commonly asked question, guys. What is the scenario in the common peroneal nerve injury? In common peroneal nerve injury, what will happen? Both superficial peroneal and deep peroneal nerves are gone. Look, in common peroneal nerve injury, generally around the neck of the fibula, first of all, dorsiflexors are gone and everters are gone. Abhi dorsiflexors are, is baar dorsiflexors chale gaye, so foot will come into what position? Plantar flex position, that is a foot drop. And everters are gone, so foot will be inverted. So this time the foot is plantar flexed and inverted, and that is a equino-varus position of the foot. Foot drop is there and inverted foot is there. That is a equino-varus position of the foot. Look at that. That's a equino-varus position of the foot here. And the type of gait these patients will have a high steppage gait. If they will not take the high steppage gait, then obviously they will drag their toes on the ground. So they have a high steppage gait in case of this, the common peroneal nerve injury. So बहुत simple questions आते हैं. It's like tibial nerve injury and common peroneal nerve injury. Common peroneal nerve is the one which is commonly asked here. Tibial nerve injury is not very commonly asked question here, but you know that what will be the scenario if there is the case of the CPN injury and the common peroneal nerve injury. Okay. Short saphenous and great saphenous vein. The only thing you need to remember here, mainly from the question point of view, the great saphenous vein, which is running on the medial side, it's the branch of the femoral nerve, guys, which is accompanying them. Look at that femoral nerve over there. And femoral nerve is the one which accompanies the great saphenous vein with the name of saphenous nerve. So if you're taking the graft from the great saphenous vein, the saphenous nerve is likely to get injured. And sural nerve is the one which is running with the short saphenous vein. So if you have short saphenous vein se graft liya hai, then sural nerve will likely to get injured. This is all I want you to remember from this picture here. That when you take a graft, in case of CABG, when you take a graft from great saphenous vein, the sural nerve will get, saphenous nerve will get injured from the femoral nerve. And if you take a graft from the short saphenous vein, then sural nerve will get injured. And sural nerve is coming from both common peroneal and tibial nerve. It's a combined branch coming from both common peroneal and tibial nerve. Chalo. Just quickly through a few ligaments here, and then we're done with the lower limb part. The break is coming, guys. Look, you're looking at the ligament of the foot and ankle from the medial side. Now there's a medial arch. The main ligament which is supporting the medial longitudinal arch is a spring ligament. I just need your 5-7 minutes only, and then I'm giving the break, guys. I know that you might be needing a break right now. So this is a spring ligament here. The spring ligament is the one which is also called as a plantar calcaneonavicular. It's from calcaneum to navicular bone. That's a calcaneum bone and that's a navicular bone. Plantar calcaneonavicular ligament. And this ligament is the major ligament which supports the head of the talus here. If this ligament is broken, the head of the talus will come down, will touch the floor, and that will be a flat foot. The main ligament supporting the medial longitudinal arch, and that is the spring ligament. Whereas the lateral side arch is supported by the ligament stretching between the calcaneum and cuboid. Look at that, guys. That's a bone toward the lateral side. That is the ligament long and short. This is the long one, and that is a short one. Long and short plantar calcaneo-cuboid ligament. Plantar calcaneo-cuboid ligament, and called the long and short plantar calcaneo-cuboid ligament. See, that's a long one. The one which is below is long. The one which is above is short, and they're called a plantar calcaneo-cuboid ligament. Calcaneo-navicular ligament obviously medial side पे होगा, calcaneo-cuboid ligament lateral side पे होगा. So that is the main ligament of medial arch, and these are the main ligament of the lateral arch. That's a main ligament supporting the lateral longitudinal arch. So if you look at the foot from the plantar aspect, you can see these two ligaments. Just another picture to show you guys. The calcaneum bone is visible. If you look at the calcaneum bone, and that's a cuboid bone, that is a calcaneo-cuboid, and so calcaneum and navicular is calcaneo-navicular. ये spring ligament हो गया, and that is the plantar calcaneo-cuboid ligament. If you look at the ankle from the medial side, when you look at the ankle from the medial side, this deltoid ligament is there. And anatomically, what is the main question in the deltoid ligament? Deltoid ligament is such a strong ligament, guys, that it is attached to multiple bone. It is attached to the medial malleolus. It is having attachment to the calcaneum, to the talus, to the navicular, and it is even attached. It is attached to like 3-4 bones here. To the medial malleolus, that is the tibia only, medial malleolus, to the navicular, to the calcaneum, and even to the talus also. These are the 4 attachment for the deltoid ligament. I remember this question, though it's an old question asked like this, that which of the following bone is not giving attachment to the deltoid ligament, or also medial cuneiform was also given in the option. So no attachment to medial cuneiform. It's a medial malleolus, navicular, calcaneum, and talus. And see, this deltoid ligament, the thing about this deltoid ligament is it is such a strong ligament that doesn't allow the eversion of the foot. Like if you look at the inversion and eversion of the foot, it's the eversion of the foot which is like very less possible. Inversion you can do a lot, but eversion zyada nahi ho pata. It's a very strong ligament which will do that. And any injury to this ligament, it's such a strong ligament that generally ligament is not broken. Such a strong ligament, when it breaks, it either will cause the fracture of medial malleolus, or it can also cause sometimes the chip fracture of the navicular bone and even the calcaneum bone as well here. So you can imagine how strong this ligament is, that in the eversion injury of the foot, the ligament can be broken. Like this. Look at that. That's a eversion injury here. Combination with a fracture of the lateral malleolus. Now, when there is a eversion injury, obviously the lateral malleolus will get fractured here. The malleolus on the lateral side, that will get bent on the other side, that will get fractured here. And fracture of the lateral malleolus and the injury to deltoid ligament, they are seen together generally. So if there is a eversion injury, the lateral malleolus will be broken, and the stretch on the medial side will cause the injury to the deltoid ligament also. Whereas when you look at the foot from the lateral side, that's more important actually. The ligament which is present on the lateral side, we have 3 bands over of this ligament, all coming from fibula. Now you can see one is anterior talofibular, there is a posterior talofibular attached to talus bone, and the middle fiber is attached to calcaneofibular, guys. And out of this anterior talofibular, posterior talofibular, and calcaneofibular, it's the anterior talofibular ligament which is most commonly injured in the inversion injury of the foot. It is most commonly injured in the inversion injury of the foot. If there is an inversion injury of the foot like this, so that's most commonly, because generally inversion injury of the foot is in the plantar flex position. And in that case, anterior talofibular ligament is more in the line with the fibula, and that is most commonly injured ligament in that case, in the inversion injury. Just couple of more slides and then we're done with this lower limb part. Now there's another ligament which I need to tell you guys. Just look at the circle on that picture, because there are multiple ligaments, intrinsic ligaments are there, not important. And that ligament over there is called as a bifurcate ligament. Well guys, why do we call it a bifurcate ligament? The bifurcate ligament is having its furcation. The stem of that ligament is attached to the cuboid calcaneum bone, and then one band goes to the navicular, one band goes to the cuboid. So there are 2 parts of it. If you compare this, one is a calcaneo-navicular ligament. One part is called as a calcaneo-navicular, and one is a calcaneo-cuboid. Calcaneo-navicular, In fact, look at this cadaveric image. That's even better. Such a beautiful picture of this ligament. One is a calcaneo-navicular, and one is calcaneo-cuboid. Calcaneo-navicular and calcaneo-cuboid ligament. And this ligament is broken especially when the foot is in the plantar flex position. Wearing high heels, and then if there is an inversion injury of the foot here, so lateral, that anterior talofibular ligament is broken, but guys, this ligament is also broken here. So high heels, like the pencil heels, are usually the most common cause for this bifurcated ligament injury here. So when you like, okay, so when when your heels and your ankle don't play nicely, then this is what can happen. This bifurcated ligament can go. The anterior talofibular ligament and the bifurcated ligament, the both ligaments can go together here. Generally, they are seen, their injuries seen together only. Lisfranc ligament, इसलिए बोल रहा हूँ because it is a question asked in the recent time, guys. Lisfranc ligament, it's a ligament connecting the medial cuneiform to the base of second metatarsal. That was the only question asked. That's a Lisfranc ligament. Look at that ligament over there. It is connecting the medial cuneiform to the base of second metatarsal. And here is a radiograph. If this ligament is broken, if the Lisfranc ligament is broken, guys, this ligament is broken, the space between the base of first and second metatarsal becomes very evident here. Look at this picture. Such an evident space over there. You can see the base of second metatarsal and base of first metatarsal. The space is quite widened here, and that is because of the Lisfranc ligament injury. Chalo sir, I think this deserves a break here, 100%. So we're done with some part of histology, we're done with the embryology, general and systemic both, we're done with the upper limb, we're done with the lower limb. This is a time for the break. I'll give you exactly 20 minutes break, guys. Come back in 20 minutes, get your tea, coffee, okay? उसके बाद आते हैं, and then we'll start with the head, neck and face and neuroanatomy. बड़े नहीं हैं, those topics are not big, but obviously we need a lot of attention in that here. So forget about MCQ, beta. MCQ, if I'll get into that MCQ thing, it will go very, very long. I'll quiz, so I can conduct in your group also. I had a plan to conduct the quiz also, but the problem is I have to keep switching from this presentation to other presentation for the quiz. So I'm thinking that let's get over with this. Quiz to hum kar lenge, quiz to we can do it later also. So that is not an issue. It is based on the same topics only. So let's take a break and catch this.